but it is a conveyor where there is a very thin, very small space for the instrumentation over the foot plate. Here you can see this ablative foot plate with a thick crura. These are the few variations we get in the posterior crus. This is the one interesting case recently I have done. This is this patient where there is I can see only the posterior crus. There was no, this foot plate is not at its sorry, the suprastructure step is a very obliquely placed. So these are the variation in the posterior crura. What is the strategy to deal with the posterior crus? Partially drilling and weakening of the posterior crura is our strategy. Here you can see the drilling of the crura foot plate junction to weaken of the posterior crura. Here is also the same thing. Here you can see the very thick crura, and we can drill out the thick crura at the crura foot plate junction. Here again the same. It's a very thin crura, and vertically slice out the foot plate crura. Here again is the posterior crus. We have drilled out the posterior crus at the crura foot plate junction. So the partially drilling and weakening the crura, our goal is to achieve the exposure to the foot plate for the further foot plate handling. This is a small video where you can see that there is a thick crura, and with a quadrangle handpiece and 0.4 meter diamond burr, I am drilling out the posterior crus. Initially, I vertically slice out the crura, and in the next 1 or 2 attempt, I will weaken this posterior crura at crura foot plate junction, so that to get exposure to the foot plate for a fenestration and further surgical steps. This is how we get the exposure. By doing this, so we can get the full exposure of the foot plate, and we can do the fenestration. And these are the few images shows. This is a drilling of crura, and this is the perfect alignment or perfect placement of the piston with the intact suprastructure of the stapes. This is how we remove the suprastructure. You can see there is a very thin anterior crus, while this is a drilled out posterior crus. The conclusion: the understanding the anatomy of the foot plate and its friends, that is the crura and crura foot plate junction, is important, and partial drilling and weakening of the posterior crus to get the proper exposure of the foot plate is very important. Thank you.
Thank you, Dr. Kalyankar. Topic is open for discussion.
Hello. Kalyankar sir, on this side. Do you suggest drilling of the whole of the posterior crura to the level of foot plate, or just weakening it?
That depends upon the thickness of the crura. If the crura is very thin, then I can break the crura at the crura foot plate junction by drilling the posterior. If it is quite thick, then I initially vertically slice out the posterior crus, and at the end, at the crura foot plate junction, I drill the posterior crus.
No, but the proponent of the vein graft people, the people like me or somebody who does vein graft, they totally flatten the posterior crura to the level of foot plate. So do you suggest doing that, or just weakening of the crura?
You can flatten the crura up to the foot plate level. No problem.
Thank you.
It's a good presentation.
Hello, Dr. Maruti. Actually, is removal of posterior superior, overhang, synonymous with aticotomy? That is what you said actually, aticotomy.
This is the bone overhanging. It's a parts of some attic and the posterior superior bone we remove.
So posterior superior overhang removal is synonymous with aticotomy. Do you want to say that? I differ.
There is small aticotomy. This is part of attic and the posterior superior bony canal wall we can remove.
I think that is a part of the outer attic wall. That is part of the outer attic wall.
Not really.
Very difficult to fracture. Even if you fracture it, the anterior half of the foot plate may come out. Yeah. So have you come across for a difficult anterior crus? So whatever you... Okay, thank you.
So I wanted to ask you, it's a good presentation, but you spoke about the different ways how you would manage the posterior crura. depending on the thickness, so that you remove it. It's fair enough. But you also mentioned something about reverse stepidotomy which you do. So I couldn't understand.
The reverse steps of the stepidotomy. I do the fenestration with the intact suprastructure, and I put the piston before that, and later on I remove the suprastructure. Reversal steps of the.
So you remove the
plastic.
suprastructure after putting in the
Yeah,
after putting in the piston, and don't you find it difficult to put in the piston? I mean, remove the suprastructure after putting the piston, or that's only for a floating foot plate? What is the main reason why you do that?
Basically, the foot plate get hold by the crura. First thing. Second thing, that's why I am addressing the posterior crura in a way that we should get the proper space for the instrumentation over the foot plate. First thing. And once you weaken out the crura, once you open the space for the foot plate, there is a quite enough space for the fenestration and placing the piston. And once the crura is very weak, then it is easy to outfracture the crura.
So just correct me if I'm wrong. So first you would expose the crura, expose the foot plate. You remove the posterior crus.
No. First I weaken the crura,
Correct.
Expose the foot plate,
Correct.
do the fenestration, put the piston, and then I remove the suprastructure.
Then remove the suprastructure. And what is the advantage you feel in doing that? Is it specifically just for the
I feel
stability part?
Stability part.
For the stability part.
And also it will help us in measuring the correct length of the piston. And the so-called incus mobilized or lateralized, medialized, all that is avoided. I also do this technique.
Thank you, Dr. Meghnad sir, Dr. Minesh sir, and all. Thank you, Dr. Maruti sir. Please collect your certificate. Dr. Guravli, hand out the certificate. May I request Dr. Ramesh Rogal sir to have his presentation? Sir, please start.
Hello, am I audible?
Yes, sir.
Good morning, everybody. Good morning, judges. I'd like to share my experience about the cochlear implant program which we started. It had been a very fascinating and you can say tough journey, but we could do it. As you all know, the incidence of congenital hearing loss is very common. Is more than any other congenital conditions which come across like spina bifida, Down syndrome, etc. The assessment and the treatment has to be as early as possible. Earlier the rule was 136, that is detection of the deafness at the age of 1 month. By 3 months you should go for hearing evaluation, and by 6 months it has to be early intervention. But now the protocol of 136 is changed to 123. The youngest patient you can operate is 3 months. Why early detection? Because there are difficulties in development of vocabulary, articulation, intelligibility, social adjustment, behavior of the child, etc. Everything is affected. And hearing loss in children can lead to the delayed speech and language development, learning problems in school, feeling bad about himself, they are having troubles in making friends. And earlier methods which were described, they have been like, only high risk children are to be screened. It's not like that, because we were missing a lot of patients, those who could be diagnosed. School performances, because of the hearing loss, with the mild to moderate loss, they fall behind the grades. Severe hearing loss, they struggle in 8th and 9th standard. There is a lot of gap between the normal children and the children with hearing loss. It goes on increasing over the time, and they need support from parents and school to keep them up with the other normal children. So what is the responsibility of we people as an ENT surgeon? We should test children for hearing loss at birth. We should retest if they fall in the test and retest after 1 month. We must refer them. If they still fail, we can have a detailed sort of a testing. And only doing OAE is not sufficient. There is a lot of parental concern about the detailed testing. As you all know, the program of cochlear implant, it starts with awareness, screening. There is a referral center. We go for imaging. Then there is a pediatric evaluation. There is a lot of counseling which goes on. Then there are sanctions. Then comes the surgery. And the most important part comes after surgery, that is AVT. This is a flow chart which shows how we proceed for the particular cochlear implant procedure. Starting CI program was difficult because it is dealing with the special sense, and there was a team building which was needed. A lot of awareness was created because of the condition which goes neglected, and we keep on meeting pediatrician, gynecologist, and ENT colleagues to create awareness about the early intervention, surgical intervention in the deaf-mute children. What is the team? The team consists of ENT surgeon, audiologist, speech verbal therapist, social workers, counselors, pediatric clinical psychologist, pediatrician, neuropediatrician, language and hearing therapist, radiology, imaging specialist, anesthesiologist. As I have told you, it is concerned with a special sense, so it requires a lot of efforts, and strict aseptic precautions are to be followed during surgery because of the prohibiting cost of the implant. Revision surgery is a really difficult task. I have already told you about the team building. We have team at United Sigma Hospital. Professor Milind Kirtane had been our mentor. In my experience, up till now we have performed 32 cases since we have started the CI program. Out of that, EDIP scheme cases have been 12, self-funded 20. Above age of 8, there were 3 patients. We had encountered congenital deformities in 2 cases. Training of otologist is needed by cadaver dissection, attending workshops, knowledge of the audiology and AVT, radiology, and getting oriented to the CT and MRI findings. What are the patients we do get? We get few patients, those who are self-funded. There are partially funded patients, those who say we cannot arrange for this much of fund. They try to organize some funds. Then we have fully funded patients like different schemes. Different schemes are ADIP scheme by central government, then the Prime Minister Fund, Chief Minister Fund. There are different charitable organizations. Yesterday I was talking with Dr. Manoj Malikot. They have got a CI program in Kerala where bilateral deaf-mute child below age of 18 months, both the implants are provided by the government. Same situation is there about the funding. It's very easy in Karnataka, Goa, Madhya Pradesh, Rajasthan. State government is taking a lot of efforts. The situation in Maharashtra, I'm sorry to say, it is very sad, and we don't have anything except ADIP scheme at our sleeve, and of course individual fundraising by different charitable trusts. There are few trusts they call being human, but they are inhuman in not sanctioning the funds to people outside Mumbai. This is something which I was not able to understand. Then we have to talk with our obstetrician colleagues, explain them the need of the screening test which is to be done for newborn. Every newborn ideally has to be investigated for good hearing. Pediatricians, they should be asked to give more attention towards the patient of the suspected patient of deafness. They have got very busy OPD, and what they do, we have seen very often, that they just clap the hands and they say, yes, yes, hearing is good. Clapping hand and testing hearing is not a solution because it is a vibrotactile sensation, and openly if you are doing clapping hands in front of a child, he is going to respond. So that method needs to be discouraged. And they must be requested to refer patients as early as possible. Meningitis patient, I like to make a special mention because cases of meningitis, this is a most urgent emergency sort of a situation where we can do cochlear implant procedure in them, put a dummy implant, and subsequently when the situation is settling down, true implant can be put. General practitioners, they also are needed to be educated. Different government programs also should reach them, and they should know where to refer the patients. Thank you very much.
Thank you, Dr. Ruel, sir. Topic is open for discussion.
Yes, sir.
My experience in cochlear implant. So just I want to know that 3 patients above 8 years. So what is your experience after doing the cochlear implant? How they are doing now? Because categorically,
categorically I mentioned 3 patients.
3 patients above 8 years. Because
above 8 years.
because the results are as the age is going on for the prelinguals.
I understand.
So it is variable. So what is your experience out of these 3? Whether they have you seen their progress after 8 years?
The progress is not very satisfactory.
Okay.
I must admit.
Because those are most probably 8 years. They are not funded by any
No,
scheme.
they were
Nothing.
They were self-funded.
Self-funded. So expectation
one
of the
was an
parents.
adult. One was an adult who was related to a doctor who had a sensory neural loss and was not having any benefit out of hearing aid using for a long length of time.
And sir, similar type of for the other audience, because most of the time the prelingual they miss the train, and after that they come to know that in Sigma this program is going on, and at the age of 18 or 21, 22, they just come and ask, क्या अब हमारा हो सकता है?
Lot of valuable time. I entirely agree with you, sir. Lot of valuable time is lost till the patient reaches us.
So
usually they reach us after 5, 6 years, 8 years, 10 years, and they expect us to do surgery.
So in this case, suppose a friend or some relative, if he is asking for 21 years and not language is developed, because one is 8 years more 3 patients. If such patient will approach to you, what is your advice to them?
I'll definitely discourage them because the benefit is not going to be more. But as you know very well, if it is an adult postlingual because of head injury or sensory neural loss,
No, I'm asking about the prelingual.
Prelingual
If they miss the train, I think
We
you
should
should not do that
We should
thing,
not do.
because it is the electrical sound continuously going there, and
Yeah.
they are not understanding what for this sound is there,
Yeah.
and it will be the non-user or it will be the psychologically they will get disturbed. Okay.
yes, sir.
Thank you, Dr. Vedi sir, and thank you all.
Thank you.
Thank you, Dr. Ruel sir. Please collect your certificate. May I request Dr. Jagtap sir to give this certificate, please. So with this, we come to the conclusion of a very good consultant award paper. Thank you, respected judges, for your valuable assessment. May I request Dr. Savji sir to felicitate our chairman, Dr. Jagtap sir. Moment. Dr. Savji sir to felicitate Dr. Jagtap sir. Thank you, Dr. Jagtap sir, being chairperson. I request Dr. Ritesh sir to felicitate Dr. Anil Solanke sir. Thank you, sir. Yes, sir. Thank you, Dr. Anil. I request Dr. Atul Pore, our treasurer, to felicitate Dr. Guravle. Thank you, Dr. Gurole. Thank you all. So with this, we conclude this consultant award session. Thank you. So I take over with this mic to Dr. Atul Pore for so next session is faculty lectures. So I invite our faculty, respected Dr. Meghnad sir, for his speech. For this session, may I request Dr. Pratibha Shitole to chair the session. Dr. Prasad Swami sir to chair the session. And Dr. Chandrasekhar Chatre. Dr. Sachin Nagare to chair the session, please.
Anywhere. Anywhere you can. Good morning, the respected chairpersons and the august gathering, seniors of the dais, friends, and our PG students. So this navigation is a teamwork, and the electronics engineers have worked very closely with the medical team to make this navigation happen. So what is this navigation?
Sir, excuse me, sir. Please can listen silence, please, sir. Please try to listen. Thank you.
Yeah, maybe in good olden days, when there is any dilemma, we used to cut open and see. Now that is no longer possible. So here, the most important thing is when you want to do the navigation, first thing when you ask a CT scan, you have to ask axial scan, 1 mm thickness, contiguous cuts. So it can be less than 1 mm, but it should be contiguous cuts, and the CD or the file should contain only this data and nothing else. Otherwise the machine doesn't recognize and you will be in trouble at the time of surgery. So this contains preoperative imaging in this format, and this has to be executed intraoperatively. So what all we do is use like same thing as car navigation. So what is this navigation? In olden days, for traveling through the ocean, the triangulation and trilateration mathematics were used to know the position of the ship. Same thing is used here in this intraoperative navigation or surgical navigation. This is also called computer assisted surgery. It's a surgical concept and set of methods that use computer technology for the pre-surgical planning and guiding or performing the surgical interventions. So this is a typical machine with a monitor, and this is the localizer. There will be a software, and there is a patient reference electrode. This is the patient reference electrode, and this is an instrument electrode. There will be special instrument to use with this navigation, and we require the most recent imaging data of the patient. And there are two methods by and large. One is the optical, like there will be infrared emitting eyelets will be there, and that will be recognized by the camera. There will be 2 or 3 or 4 pointers, and there will be 2 cameras, and that's how we understand the position of the instrument. And the other technique, electromagnetic, there is an emitter, and we look into that. Most of the ENT navigations are electromagnetic. The ability to identify a point on the patient images that corresponds to the same anatomical point on the patient is the navigation. So this is the optical localization. But the problem with optical tracking is, if there is any object in between the instrument and the camera, then the optical tracking doesn't work. The lines of sight issues are there in this, and must always be considered in planning the how to position the camera. Most of the most of the times it is electromagnetic. How this works? There will be an emitter here like this, okay? And when this emitter is or it's a localizer and it's positioned next to the surgical field, it should be with 15 centimeters away from the surgical field. That generates a local electromagnetic field in which there are over 60,000 unique field strengths. So there are 2 copper coils in the instrument tracker, and the patient tracker reports the field strength they detect. From the unique field strength, the system knows the location of the instrument. So it's an electromagnetic. The problem with this is, we understood that with the optical, the sight, there should not be any object between the camera and the instrument, whereas in the electromagnetic, there should not be any metal or magnetic instruments. This emitter will give a field strength of 50 centimeters, so there should not be any magnetic object in the 50 centimeters. So main problem for this is, so what is the routine OT table? The head end of the OT table is a magnetic one, so that hinders with the electromagnetic functioning or navigation functioning. So if you are planning to have a EM navigation, consider a head end of the table or head piece is a non-magnetic one. So if there are some, many times what we have observed, there are some iron trolley, instrument trolley, so we were not getting the thing. The moment you keep it away, out of 50 centimeter range, the navigation starts performing. So this is one important point, metal interference. So the flow of how to use it is like this. So you take the CT scan, already we discussed, there is a 1 millimeter at least thickness cuts, 1 millimeter thickness cuts, contiguous cuts, and only in the Excel format. And save it is on a USB or a CD, and load this data into the machine, and then you use the navigation, start using the navigation, and do the registration. This is the way we do the registration, and then you are ready for the navigation guided surgery. So what is the evidence? There is a lot of evidence about the IGS, image guided system or a navigation. Perioperatively, the morbidity will be reduced in the endoscopic sinus surgery. This has been studied and published by Delgoff in the otolaryngology head and neck surgery, and the major and total complication rate has come down very positively. See, the major complications have reduced, the minor complications have reduced with the use of the navigation. Well, of course, this study is done when the surgery is performed by seniors and juniors as well. 70% reduction in the major complications, which is a very important thing for our ENT fraternity. And the specific complications also have come down. All complications incidence has come down with the use of navigation. The proven need for IGS, especially about the choanal atresia, was published, and comparison of the endoscopic sinus surgery with and without image guidance was published by Fried, and image guidance system for minimally invasive sinus and skull base surgery in children by the Margot, and all these studies support the use of navigation or image guided system. The use of IGS in endoscopic sinus surgery may reduce the complication associated with the procedure and allow a more thorough operation. The most important thing is we are able to do a thorough operation, a complete operation. Because all of us have experienced, whenever you tell a sinus surgery, propose a sinus surgery to the patient, the next word what the patient says is, "Sir, ये तो बार-बार आता है ना sir, surgery के बाद भी." So this is the, unfortunately, this is the reputation the endoscopic sinus surgery or a sinus surgery has. The patients believe, very strongly believe, that sinusitis means they suffer for they're prepared to suffer for their lifetime. They come to us only when there is a complication. But we know that the sinusitis disturbs the quality of life, their performance very badly. So we need to treat them. And why they are not coming? Because of the bad reputation. To remove this bad reputation, I think we start doing a complete surgery. Many times, especially the juniors, may live certain diseases because of lack of confidence, and that is fully justified. Don't do any harm if not good. So that is fully justified. But how to come out of this problem? Probably navigation. Navigation is a very useful tool for the, it benefits the juniors. And this improves the intraoperative safety. This leads to safer surgery in certain situations, including the revision and frontal procedures. When you are operating on a frontal sinus, whatever may be you are experienced, there will be an occasion, 1 out of 100 or 1 out of 200, you will be in dilemma, where are you? And you may spend more time to reach the frontal sinus. Whereas if you have a navigation, you will reach faster. Your operating time will reduce. We all know very well that sinus surgery results and depend on the mucosal trauma. The mucosal trauma is more, the more time you operate. So you have to reduce the time of duration of surgery. And also it facilitates a minimally invasive endoscopic approach for a sinonasal and skull base pathologies. So it gives the precision, safety, and reduction of the operating time, reduction of the complications, and of course, we don't have any guidelines from our association, but American Academy of Otolaryngology and Head and Neck Surgery, they suggest navigation whenever you are doing a frontal post-rhythmoidal sphenoid sinus, and revision surgery whenever there is a disease abetting the vital structures, CSF rhinorrhea, and neoplasms, benign and malignant neoplasms. So similarly, the Australian expert panel also recommends the similar things on IGS, and they suggest even for the mucoseals also. So now, recently we got the addition of the navigationable balloon, and that balloon sinuplasty is also a comfortable thing, and that's also nowadays feasible. So why I am interested in the navigation? I want the navigation for the frontal sinus surgery. Maybe with the experience I may be able to do the surgery, but when I use the navigation, I will do more confidently without rise of my heart rate and blood pressure. So navigation is for my safety as well, not only for the patient safety, for my safety also. Maybe after crossing the 60, I should look at my heart rate. So looking at the frontal is the most interested for me, and the boundaries, anteriorly the agornizale, laterally the orbit, posteriorly the interval of the bulla, attached to the skull base, medially the middle terminate. These are the anatomical boundaries. But the end of my surgery, the boundaries will be anteriorly the frontal beak, laterally the lamina peperosa, posteriorly the skull base, and medially the uncinate process, skull base in the narrow frontal recess and the middle terminate. So challenges for frontal recess surgery, why I want navigation is the anatomical variations are too many in a very narrow dimension. This becomes more difficult or more so important when there is a postoperative scarring or stenosis. And if I want to avoid this happening in my surgery, I should preserve the mucosa. To preserve the mucosa, I must know the frontal sinus drainage path anatomy more confidently than explore and see and then do. By the time I damage the mucosa, then what can I do? Gone. So once you damage the mucosa, you can't put it back. Similarly, I think I keep telling my juniors, two things are important for me. Most important thing, the mucosa in the frontal recess and in the ear, the canal wall skin. I can't get any alternate or substitute for these two things. So mucosal preservation is possible by working on the drainage path, not just like that, and only on the drainage path. Of course, we require sharp cutting instruments. So before that, even though you may be using the navigation, you have to study the CT scan thoroughly, especially the frontal recess. Yesterday also we studied before the surgery about the frontal beak, lacrimal sac, agar nasi, entorhinolaryngologist artery, and the most important thing is the anterior-posterior and horizontal dimensions of the frontal recess. Of course, horizontal dimension you can study on the CT scan. How to understand the anterior-posterior dimensions? You count the number of cuts from the frontal beak to the entorhinolaryngologist artery, or that is the skull base. So we have certain cells. I study the cells in this order: anterior to lateral group, the K1 and to K4 cells. And the posterior group are frontal recess cell and supraorbital cell. The anterior and middle group are, you can have K1, K4 and interfrontal or midline frontal cell. This cell we have seen yesterday before in the live surgical demonstration. So we try to understand, put these cells in a schematic representation. So now you see, so this is the nasolacrimal duct area. This is the lacrimal sac, and this is the agar nasi cell. And a cell above that is the K1 cell. Same thing if you see in the sagittal guts, agar nasi and K1 cell. And here you have agar nasi, and there are two cells, and all are below the frontal beak. This is the frontal beak. These two cells are below the beak, so this is a K2 situation. So here there is agar nasi cell, and there is a cell above that going into the frontal sinus, and there is a cell here. Oh, pointer is not coming. Oh, okay. Yeah, okay. So this is the, when I turn my head, I think mic is not perfect. Okay. So this is the agar nasi cell, and you have a cell above the frontal beak. So what is this? This is the frontal bular cell. So what is the definition of the frontal bular cell? Anybody from the juniors? What is frontal bular cell? Okay, frontal bular cell is the cell which has skull base as its posterior wall. So here, so this is the frontal bular cell. It is very difficult to recognize the frontal bular cell in the coronal cut. You can recognize very easily in the sagittal cut. That's why you must study the CT scan in all the three planes. So here is agar nasi, there is a K1 cell, and there is a one more cell above that. This is crossing the frontal beak. So this is the frontal beak. It's going above the frontal beak. So this is a K3 cell. From here, the height, if it is crossing the 50% of the height, it is K4 cell. So now you can see agar nasi, K1 cell, and this is the K4 cell. That is the K4 cell, because it is crossing the 50% of the height of the frontal sinus. So I think I am clear about the frontal recess cells. So here is much more little complicated situation. Unfortunately, the CT scans or patients don't read the textbooks. So this is the Agar-Neisser cell, there is a K1 cell, and there is a K4 cell here, and there is a frontal bular cell. So now you can see the anterior ethmoidal artery here. This is a beak-like defect in the lamina pepracia, and this is the anterior ethmoidal artery, and the cell above that is the supraorbital cell. So we are understanding all the cells. Of course, this is now you can see only Agar-Neisser cell here, and that is the interfrontal cell. Exactly same thing what we saw yesterday, the sinus surgery demonstration patient. So on the left side you see the K3 cell. K3 cell can be identified very easily in the coronal cuts. Frontal bular you cannot. And why it is K3? This is the frontal beak. Why do you call it frontal beak? This is a horizontal plate of bone between the two lamina pepracia, and a cell above that is the K3. If it is crossing the 50% of the height, it is a K4 cell. And here you can see on the left side there is a frontal bular cell you can see on the CT scan. This is the frontal bular cell. On the right side you see a K3 and K4 cell and intrafrontal septum. And that is the K4 cell. On the left side there is a K3 cell. And you can see the frontal bular cell and also K4 cell, very big Agar-Neisser cell. Oh, video is not coming. Some problem.
We can see the natural ostium of the sphenoid sinus. I am removing the sphenoid sinus anterior wall up to the groove of the sphenoid.
Some problem with the computer. Your LED.
Then the Agar-Neisser anterior end of the medial sulfonate transform on the axial side. Again the medial sulfonate.
I'm not
transform. Conforming with the I'm using a navigation. Is it okay? Without now, let us see what are the structures we are seeing, then we will reconfirm. So this is the anterior ethmoidal artery. Okay, this is the supraorbital cell tract, right? And so we are having here, this is a very big Agar-Neisser, right? And this is the uncinate process which is attached to the skull base and partly to the lamina pepracia and partly to the medial sulfonate. Now there is a one cell here. I don't know whether it is a frontal sinus. Sister is saying no, it is not frontal sinus. So this is another sinus we have. There is another cell we have here. So these are the three cells we are having. So one of the three should be frontal sinus.
I selected a unique, very rare complex anatomy of the frontal sinus.
In fact, I am observing what all we said is right or wrong.
And that is the anterethmoidal artery. That is the anterethmoidal artery. This is the supraorbital cell.
The F frontal sinus. So that is the now checking whether the navigator is corresponding or not. Of the nose structure, that is the lateral wall of the nose. You can see very clearly that is very correctly placed, and that is the middle turbinate, fine. And this is the lamina peperosia in relation to the agar nasal. Yes, correlating.
Always confirm the efficiency of the navigation,
Frontal beat
correlation of the navigation
correlating.
with the known points on the field.
Now, coming into the
Like the posterior wall of the frontal, the maxillary sinus. We are very sure, there is no doubt about it.
yes, again it is
Or interval of the sphenoid, any known, or roof of the nose. You have to correlate one point in the horizontal direction, one point in the anteroposterior direction. That's what exactly we are doing.
This is the lamina peperosia, and that is the middle turbinate or sulcus. The lateral lamella of the cryptiform plate. So this is the skull base, and now that is the roof of the supraorbital cell tract. Yes, above that is the frontal, and when you go laterally, so that is the roof of the supraorbital cell tract, and above that is the frontal, and that is also the roof of the supraorbital cell tract. That is the posterior extent of the superior extent of the supraorbital cell tract. And this is also supraorbital cell tract. But more anteriorly, that is the uppermost part of the supraorbital cell tract, superiormost extent of the supraorbital cell tract. Now we have a, now let us come here, let us see the agar nasal, and that is a K3 cell. It is a cell above the frontal peak, and we know this is the frontal peak. That is the frontal peak. If that is the frontal peak, cell being above the frontal peak, superior to the frontal peak, this becomes the
K3 cell.
You can observe that. Again, let us see the where is the supraorbital cell tract in the axial cut. That is the supraorbital cell tract, and that is the supraorbital cell tract. Anterior to that, in the axial scan, will be the K3 cells, two K3 cells. So that is the K3 cell here, and this is the another K3 cell. Both you can see in the axial cut as well as in the coronal cut. This is the one laterally placed K3 cell. This is the
A little complex situation. So far we have opened many cells, but we couldn't see the frontal sinus.
If I go above, probably I'll get the frontal sinus.
Yeah, now I have entered the frontal sinus.
Yes, I have
That is the
entered
frontal sinus.
But same thing I will explore now. And
So
then
once
again,
I opened, understood where is the frontal, with the navigation, I am
navigator keeping a knife on the
using this is a 90 degrees curette.
rather I am removing the roof of the supraorbital cell tract or the wall between the hips.
Always remove the bone with the Blacksley, don't remove the mucosa, and remove the mucosa with the debrider.
I am using a rod for the blade.
Yet to see the frontal sinus.
Lateral wall of the medial cell, medial K3 cell.
Always, now you can see the frontal sinus very clearly.
Sinus.
That is the frontal sinus opening.
Right. Key plate.
Now this is not enough, this is a very big sinus, so you need a very big opening. You have to remove the mucosa very precisely.
Loop of the supraorbital cell tract, which is forming the floor of the frontal sinus partly and partly.
So the most important thing is you have to understand
Now I
which is the sinus and what are the valves. What are the common valves?
almost you don't see the capital now. The lateral capital is totally different.
Finally, at the end, we are having a very wide opening to the
Opening.
frontal
Can I
sinus.
have vertical through here? Let me remove the roof of the supraorbital cell tract as well as which is also floor of the frontal sinus here.
Yes, sir. No, you can ask the table manufacturer material similar to the X-ray table. Yeah, they will give the CM compatible head. Only head end you can take. That's enough. Because it is the range of the radius is the 50 centimeters, so that means around 1.5 feet. That will be okay. Cost navigation nowadays it is costing around 25 to 40 lakhs. What I suggest is if 2-3 people in the city they negotiate together, you will get a very better price.
Thank you very much, sir.
Thank you, sir.
Now the next topic in this faculty lecture session, this is a new domain that we can see. We lot of us see about the TM joint disorder. So I request Dr. Rajesh Yadav to come on the stage to give his talk on TM joint and ENT surgeon's perspective.
So very good morning everyone. I'll be talking about TM joint disorder. If we see 10 patients, at least 2 patients will be a TM joint patient, and we are not aware of that, and we just treat it and the patient doesn't improve. So let's know about TM joint. So what's the peculiarity of TM joint? It's a bilateral diarthrosis, means right and the left functions together. The articular surface is covered by a fibrocartilage instead of hyaline cartilage, and it's the only joint in a human body to have a rigid endpoint. That means the closure is the teeth which makes the occlusal contact. So let's see the functional anatomy of TM joint. So this is the condyle. This is there in a glenoid fossa, and it's in between lies the disc. This disc is divided into 3 parts. The red is the anterior band, this green is, this is intermediate, and this pink is the posterior. Anteriorly is attached to the lateral pterygoid muscle, and the posteriorly it is continuous with retrodiscal tissue. This disc divides the cavity into 2 parts, the upper part and the lower part. So the upper compartment and the lower compartment. Now there is the intermediate, this part, the zone doesn't have a nerve endings. while the retrodiscal tissue has lots of nerve endings. This is how the disc looks like in a normal human being. This is a biconcave. You can see this, the intermediate zone, the anterior zone, this is the posterior zone. Let's know the biomechanics of normal TMJ. So the posterior bands lies at the 12 o'clock position, the intermediate zone lies at 1 o'clock position. So the initial mouth opening, the condyle initial 20 degree, so the initial mouth opening occurs in a glenoid fossa itself. But for the further mouth opening, the condyle has to come anterior to the articular eminence. Okay, so the first 20 degree is rotational and next is translational. So first 20 degree, this is rotational movement. This occurs in a lower compartment, while the later stage of mouth opening occurs in a upper compartment. There are various ligaments. The first one is a capsular ligament. This is very important because this has to be pierced for doing a TM joint arthroscopy and arthrosynthesis. Then we have a lateral ligament, which is further divided into oblique and transverse. So this is the oblique and this is the transverse. This limits the 20 degree of condyle rotation, while this prevents over retraction. And we have a collateral discal ligaments, which just stabilize the articular disc. So there is a classification of TM joint. There are various diseases which are included in this disorders. So we're gonna include those things which commonly comes to our practice. Jaw dislocation. This is the most common thing which comes to our casualty. Patient with muh khula ka khula reh gaya. So what happens in that? In jaw dislocation. So in jaw dislocation, what happens? The condyle come anterior to the articular eminence and stays there, and doesn't goes back. So there are types of jaw dislocation. So the first is the anterior jaw dislocation. This normally occurs after yawning or achieving. Then there is a posterior jaw dislocation. If somebody punch you on a chin, there is a posterior jaw dislocation. Then there is a superior jaw dislocation. If there is a punch in a chin with an open mouth, there is a, and there can be a lateral jaw dislocation. Normally occurs with the fractures. So the clinical features will be patient will unable to close the mouth. There will be pain. There will be emptiness in a glenoid fossa because the condyle will not be there in a glenoid fossa, and there will be a malocclusion. So we all know that whenever such patients come, we have to reduce it. So there are lots of ways of reduction. The first one is the Hippocrates method. So what we have to do with the molar, we have to give a pressure downward and a backward. Another technique is a wrist pivot method. What we do, we put your wrist on a mandible and the fingers on the molar. With fingers you push downward, and with wrist you push upward. Third technique is interdental block. In this, what you do, you make a block of a gauze piece, you put between the teeth and try to press over here. Okay. All these techniques, sometimes you may require a sedation, intravenous analgesia, and there is a chances that your finger may be bitten. So this another technique is called syringe technique. So what we do in a syringe technique is we place a syringe in between upper and a lower molar, and the patient is asked to bite the syringe, and this will roll back and forward. This will act as a rolling fulcrum, and the molar will roll over the syringe, and the mandible and condyle will glide posteriorly. Aftercare. So you have to give a support of a chin while yawning, use a circular fixation for first 24 hours, limit mouth opening to 1 finger, but it doesn't happen. So if, once you can reduce, twice you can reduce, but if the patient is coming, if it's coming frequently, what we have to do? We are ENT surgeon, we have to do something, we have to operate on this patient. So there are various options which are available. You can do arthroscopic procedures like aminoplasties, lateral pterygoid myotomies, muscle procedures like lateral pterygoid myotomy. You can inject Botox, arthroplasties, anatomical obstruction removal, doing aminoplasties, and you can lengthen the eminence and by doing a down fracture or a bone graft. Or there are another things what some people do is they inject the blood in the joint, okay, cause fibrosis and they decrease mouth opening. So let's talk about amnectomy. If a chronic recurrent dislocation patient comes, we should keep in for a amnectomy. What we do in amnectomy, see, this is the eminence and this is the condyle. This part, the condyle comes and stays over here. So if we remove this eminence, this will move forward and backward freely, okay? So I'll show you a video of our surgery. So first we have a mark, the zygoma, the condyle, everything. This is a preauricular incision we have taken. Then the dissection is done to find out the temporalis muscle. We are palpating for a zygomatic arch. Then you take a curvilinear incision at the temporalis fascia. Parallel to the frontal branch of the facial nerve. Go below it and you will find your articular eminence. See, this is your articular eminence. You have to free it from all the capsules. This is done in local. We ask the patient to open and close mouth. You can see this. The condyle is moving, but the patient is still having a difficulty in opening mouth. So we are drilling it more. We are cutting short the eminence. And we have to check frequently. Is the mouth opening now free? See, we are checking again. थोड़ा सा there is a ब्लॉक है, तो हम लोग ने वापस किया. This much part we have to remove more. So वो करने के बाद वो बराबर आ जाता है. See this. Now this is free. See this. This is another video of amnectomy. I'm not showing this. Now there's another entity which very frequently patients comes to us. Is called disc displacement, clicking sound. Patients get clicking sound whenever opens mouth and something. So what is this displacement? Let's learn about it. So as I told you, condyle, there are two attachments, retrodiscal tissue and anteriorly is a lateral pterygoid muscle. So if there is a hyperactivity of lateral pterygoid muscle or a laxity of retrodistal tissue, this forms imbalance and this leads to internal derangement of TMJ. Your disc deranged from its place. So let's see this in video. How does the disc displacement occurs? Okay. this, your disc has come anteriorly. Now this tissue, as I told you before, that there is a nerve supply over there. So whenever it comes in contact with you get pain. So this is the reason why we get pain. Okay, we get pain over a time. There will be a clicking sound when it rubs to the intimate zone. There will be a clicking sound, and over a period of time, there will be a swelling over here. So because of this swelling, there will be a locking of a jaw. Okay. So this displacement is divided into 5. So there's a Wilkie systems in which we divide into 5. So stage 1 and stage 2 is they are reducible. Okay. So first is early reducing, second is late reducing, then your third and fourth is non-reducing, and in stage 5 there will be a perforation in the disc. What happens in this stage 1? There will be clinically patient will have a click sound. If you do a CT or MRI, it will be normal. Stage 2, there will be a few episodes of pain plus clicking, and if you do a MRI, there will be a slight forward displacement. Stage 3, there will be a multiple episodes of pain and locking of joint and tenderness with posterior edge thickening on a MRI and CT scan. Stage 4, there will be severe episodes of pain, locking of joints, and there will be obvious changes on a CT scan and MRI. And in stage 5, there will be a total lock. So there will be a perforation on a disc on a MRI and CT scan. So there is a dictum: a clicking joint doesn't lock and a locking joint doesn't click. Okay. So if there is a clicking joint, that means it's a stage 1 and 2. So there will be no locking. If that's a locking, it won't click. So what's the treatment of it? So the treatment is 80% of time it's a conservative treatment. Okay. So the patient education, medical management, physiotherapy. So it's a conservative treatment. I'll go directly on a surgery. So we can use a dental splint. This is very much important because it unloads the joint, it increases the joint space, reduce the inflammation, increase the free jaw movement. And surgery, we have to do something again. So if patient is unresponsive to the conservative treatment, in stage 3 and 4, we can do this arthrosynthesis or arthroscopy. So I'll show you how to do a arthrosynthesis. This is done under local anesthesia. It washes away the inflammatory product. It releases the adhesions and eliminates the negative pressure and improves the disc motility. So this is the procedure. This is a small video of the arthrosynthesis. Okay. We draw a line from outer canthus to the middle of tragus. Okay. A line is made, and then you plot a two. I'll just forward it. You plot a 2 point A and point B. Point A will be 0.2 mm below this line and 1 mm anterior to the tragus. And this will be 1 centimeter below the line and 1 centimeter below to the point B. And if you are in a proper place, then if you push a water, it should come from the other side of the free flow. It should come, and you should always use RL. This is more physiological than, and there are people who use 100 ml of RL. They keep it for patient for 10 to 20 minutes and 20. Yeah. So we can inject steroids, all these things. Before the time, I just wanted to show how to do a arthroscopy. There's a small video of this. So, the advantage of arthroscopy is your arthrosynthesis also occurs, and you can do a diagnostic swipe also. So you can see the movement, okay? You have to palpate you draw a line. Again, point A and point B. This is 10 mm anterior and 2 mm down, and this is 7 mm. So you first inject lignocaine in the joint, okay, to insufflate the joint with plain lignocaine. And you can see the movement of this, it will come out. See this. You can see the air bubble. Okay. Now you have to take a trocar with your index finger. Sharp trocar is inserted with a rotational movement to reach the zygomatic arch. Okay, you reach over here, and just below over here you have to slide down in the TM joint, 5 to 10 mm below. Remove this, then you put your scope. Before that, you have to put there is a outflow, you have to put a water. We have to see if the water is coming out, that means you are in a joint. And you have to make a movement. Now remove the sheet and put a scope. And this is how it looks inside. So we can do a diagnostic sweep. There are few structures which can we see. Before that, we have to put a outflow needle, because if the water stays inside, it should come out. So we put the second point is for the outflow, and we do a diagnostic sweep. There are a few structures which we can see is. Okay, so you can see this. There will be a retrodiscal tissue. This will be the synovial drape, this will be the articular eminence, and this will be the anterior recess. So the 7 landmarks which can be seen is a medial synovial drape, pterygoid shadow, retrodiscal synovial. So this is your medial synovial drape. This is how it looks. It takes practice to identify structures. Then this is a lateral pterygoid shadow which we can see. You can see the fibers. So this is the protuberance. So this is a retrodiscal tissue, this part. You require a continuous irrigation, and then the anterior recess. For seeing an anterior recess, you have to, okay, this is intermediate zone, and then there you will find a anterior recess. For anterior recess, you have to ask the patient to open the mouth. This is the anterior recess. See this, you can see the anterior recess. Okay, this is done. Last, I have a time, I can, okay, TMJ ankylosing. So basically there are bilateral or unilateral, it can be true and false, complete, partial. Etiology, 80% it's trauma. Pathophysiology, after trauma there will be extravasation of blood in a joint space, hemarthrosis leading to ankylosing. Clinical feature will be decreased mouth opening, malocclusion, deviation of mouth opening and crossbite. And treatment is removal of the ankylosing part. We do a gap arthroplasty or interpositional. So we have started doing a TM joint. We use this TM joint reconstruction, replacement. So the material which we use for putting in between is the temporalis fascia, temporalis myofascial flap, tragal cartilage or costochondrial rib. I'll go directly to the case. So this was a female. She had a ankylosing. You can see this ankylosing. This is normal. So we planned, patient has a very decreased mouth opening. So we are taking a TM joint incision along the preauricular crease. We are opening up. See, we have exposed this ankylosing segment. Okay. So we have to remove this ankylosing segment. So we can either use a drill or we can use a chisel hammer. See, we have removed the big chunk of bone. We are trying to open the mouth, but still there is an ankylosing segment still there. So we are not able to open the mouth. So we're going to go and remove this whole bone with a drill. The whole ankylosing segment has to be out. So you see the mouth opening now. This is around 3.5 centimeter. And then we are taking a temporalis myofascial flap. We rotate this flap and we put it in between the in that space. This is the post-operative picture, and this is how the patient look out post-operative. Thank you very much.
Sir, any experience of using a laser in TM joint disorder?
So
a non-invasive technique.
No, non-invasive. Invasive may what we arthrosynthesis if there is a if there is a adhesions. So we use a NDAC laser. I have not done it myself because there are stages of arthroscopy.
Yeah, definitely.
Stage 1, stage 2, stage 3. I'm in stage 1 right now. So stage 2 में अगर डिस्पेस्ट है गया तो उसको सूचर लेके उसको ये करते हैं.
Because a lot of dental surgeons are doing a TM joint disorder, especially a disc arrangement. So they are using a non-invasive laser by photobiomodulation technique. So obviously it's required 2 to 3 settings, but patient do get better.
So what
with
they
this.
exactly do?
They radiate that TM joint area with a soft tissue laser. So which decreases the inflammation and edema.
Doesn't make any sense to me.
Rajesh?
It's not a occlusion problem. It's not
disc dearrangement, disc arrangement. In those cases.
I don't think so.
Rajesh, excellent presentation.
Thank you.
We all loved it. You must have realized by how people clap for that. The second thing is, can you approach the joint from inside the mouth? along through the RMT region, can you go up to the joint there?
For scopies?
For scopies and all.
No, but this is much better.
Direct approach you feel?
Direct, because
immediately.
we require both ports.
Yeah.
2 ports we require, so
yes.
that the water should come out, because it's a very small joint.
Okay.
So what we do in a knee joint, there also we require 2 ports.
Okay.
The water should go in and it should
come out.
So
you always take consent for facial weakness
yes,
in these patients?
Always.
Okay, I would request Dr. Prasad Swami to felicitate Dr. Rajesh Yadav sir, please. Now our the last व्हिडिओ दाखवणार आहे छोटे छोटे दाखव Now the last lecture of this session is by Dr. Supriya Kokne. She is going to give us, rather than lecture, these are short videos about all the cosmetic surgeries that an ENT can do. Yesterday she has given an excellent talk and it's a continuation of that. So I invite Dr. Supriya Kokne to show her the cosmetic videos. Exactly. Thanks के नहीं, but pain के लिए, but pain के लिए उससे ज़्यादा अच्छा तो ऑर्थोसेंटेसिस है. सुप्रिया ना? cheaper.
असं राहिलं चालेल का ओपन करून?
So
yeah,
I've just prepared some clips. Basically, it's not a full video, so I have to just showing the steps of 3-4 procedures. So hope you understand that.
Silence, please.
Yes. So this is a hair transplant patient. Oh, I'm so sorry. How? Excuse me. Pause कैसे करायचं? No, but I have to pause it and I have to explain it. Here ना ना. नहीं pause करायचं. हे हाँ मध्येच थांबायचं. नाही मला इथे थांबवायचं आहे. Okay, so after counseling, after deciding how many grafts we have to take, we have to start with the marking. With the patients and our experience, we can start doing a marking. Mostly we have to leave 4 fingers from the brows for the forehead. So this is a marking. Then we have to trim the hairs because it's a 0-degree trim. We have to extract the follicles. So with the trimmer, we do a 0-degree. Then we give local anesthesia in the donor area. So donor area is above the ears and goes behind in the occipital region.
Please, silence, please.
Yes. So here local we are giving, and then we are extracting with our micro drill and with a punch. And then we store it. We segregate the single follicles and multiple follicles. Mostly single follicles are implanted in the frontal area so that it will give a good defined hairline. And we are planting here. This plantation is a feather type plantation. So We just don't touch the roots, because if we touch the roots while planting, then there will be damage and there will be loss of roots. So here we have planted almost 3,000 grafts. So this is and we do dressing after that. And follow-up is just 1 day for the dressing removal. We can follow up the patient after 1 month also. It's post-operative, just saline spray and antibiotic for 5 days. So this, it's 3 hours for extraction, 3 hours for implantation. And in between there's a lunch break for the patient also and for you also. So it's a whole day procedure, simple procedure without any complications. If we, yes, actually it has become commercialized, therefore anyone is coming into this field, I expect the surgeons should take over this procedure. So this is the procedure for hair transplant. Okay, next procedure I'll show you dimple. It's also simple, so it's under local anesthesia. First we do the marking again. Marking is most important aspect. Most of the patient comes with dimple in the center side of the lip, but you have to mark it just around the angle of mouth, only 2 centimeters from the angle of mouth. So marking is very important. We give local anesthesia there. We put a needle so that from inside we have to take an incision. So we mark it from inside also. Okay, then we take an incision, because what exactly we do in dimple is we create scarring inside. We create scarring between the dermis and the mucosal layer so that there is a dimpling effect. We remove some of the fat if possible, if it's there. Otherwise, we just take a sutures, multiple 10 or 20 also is okay, absorbable sutures. And we have to just keep in mind that when we remove the needle out, we have to put the needle from the same hole, and through the dermis we have to take that needle out. And again we have to put it inside. So that's the trick here. There is nothing more in it. So just through the dermis we have to take the stitch and tie it inside the incision. So that's the only thing we have to do in this dimple surgery. And we suture it. So that's it.
This is absorbable suture?
Yes, it's an absorbable suture. Actually, yesterday, same patient it was. I just didn't add it here. Yes? No, it doesn't come out of that only I'm saying. When you remove the needle out, then again you have to put from the same hole and bring it from the dermis to the other side. Take a stitch there. And from that dermis we have to pull down and take a... Inside, yes, inside.
So
Like
she is
this.
creating a puckering.
Yes, puckering, exactly.
Puckering.
Scarring.
Scarring.
Yes, we have took out the needle from outside, and then from that same hole we are putting, and below the dermis we are going, and from the other side we are going again inside. So that's the only thing you have to do. So it's a simple thing. And the first page.
So by the time regarding that hair transplant, you are using the donor side. So if you remove hairs from donor side, the hairs will grow again in that area?
No, we are removing the roots. We have almost 50,000-60,000 roots in the back side, the
Yes.
donor side.
Yeah.
Usme se 3,000, it's not a big deal.
Not a big deal.
Yes. I'll show the lipofilling. Each dimple 25,000. Hair transplant 50,000 starts from 50,000. Yes, we bargain. No, patients bargain a lot, and because of this commercializing effect, we have to deal with this market issue. We have to come down also sometimes, but that is the main thing.
See,
per follicle, previously we used to do that. It was 100 rupees, 150 rupees per follicle. But because of this revolution and marketing, it's come down to a single chunk, like first session this much, first session this much. So minimum 50,000 we start.
So Rajesh and Supriya are giving us into, ideas of how to earn money.
No, how others are earning, you also earn. So that's the scene. Yes. Yes, we have this drill, okay? Just we have to slow down our speed of the drill and just remove it. So it's a little bit of learning there. Just we have to punch it. It's a punch there. Drill. We don't use a drill bit. There is a punch hole in that.
Yeah, I know. For putting it back, like
A back. Okay. We make holes basically, and that holes with a maybe 18 or 19 number needles also is sufficient. Or if you want to, in a frontal area, it's 20 number needle, and back 18, 19 number. We make holes with that. Yes. 98%. 10%, like 2% with like handling is sometimes it's a human handling, so it can happen. Yes. Itching? Yes. We have to spray normal saline basically. No, continuously. Till there is scarring, there is a lot of scarring after we do the procedure. So we have to continuously spray it so that there is no itching. Because once... No rolls. We have to give antibiotic painkiller for 5 days, just that, and then nice spray, but that's it. Yes, robotic ATAs, it's a new thing, but it's cost almost 45 lakhs machine. And we have good laborers, manual laborers. We ourselves are good, so I think we are more good in it other than ATAs. ATAs is a little slower, but results are good with ATAs. And we have good manual power, so I don't think ATAs is working in India more. But if patient demands, yes, we can rent it out also. Yes, robot. We also we also can do dense. It's a typical fixed amount of follicles in per centimeters, like so that much density we can give. You don't get to have this normal density as we have in wild patient, but per centimeters 30-40 follicles we can maximum give it. Otherwise, there'll be skin necrosis at that site. And if skin necrosis occurs, then there is loss of everything. Yes, and that's the main thing. Here again, learning curve matters. We have to implant it in typical direction, otherwise they come straight. So the angle of making the holes is important. How we make the holes. So there are steps where, like making holes, making lines, giving local anesthesia, where our role is very important. In other areas, we can take the help of technicians. So yesterday I had shown you about liposuction, and here I am suctioning the fat from the abdominal area. I have done tumescence and suctioning it. We have to create just a vacuum in the syringe. 10 or 20 cc syringe is also sufficient, and we have to use a cannula, 2 mm cannula, and we suck the fat. And we actually, this is a method I normally use. Otherwise, there are very different methods to separate fat and plasma. So there are 3-way cannulas and all. We can just flush it out, or some use insulin in the fat so that there is separation of fat and the plasma. But I use this crude method because we need some plasma also to rejuvenate the skin area. So I just use this chutney types, and where it settles down, and then we can extract the fat and we can implant wherever we want it. So, and the last one is a brow lift. Here we take the incision in the hairline, basically, in the hairline, just 2 centimeters from the hairline in the temporal region. I am doing this lateral brow lift. Okay, so lateral brow. This can also be done endoscopically. We are just going till the temporal fascia down, superficial and down, and then we separate it till the supraorbital rim of the lateral side. Then we pull it, okay? Then we remove the excess skin and take a suture till the gallia and tie it up. We remove the excess skin because skin plus tucking is important. So this, and then we staple it up.
This is under local?
Yes, under local. All 3 procedures are under local. All are under local. Even liposuctioning is under local. So this is a quick review or brief actually. So any questions on this?
Thank you very much, ma'am, for the excellent presentation. Now I request Dr. Shitole ma'am to felicitate Dr. Supriya Kopuni. Now I request Dr. Kirdak sir to felicitate our chairman, Dr. Prasad Swami sir. I request Dr. Bilgi sir to felicitate Dr. Sachin Nagre sir. I request Kirti Gunskar ma'am to felicitate Dr. Pratibha Shitole madam.
Good afternoon, everybody. There are 3 announcements which are very important for this. One is regarding that 12:30 to 1:30 interactive discussion with PG students, do and don'ts. So that will be there. So all PGs who are there, please don't leave the hall. They should be there for interactive session. It's useful for them, it's for PG students. The second announcement is the results of the PG award session, consultant session, poster session will be given in the valedictory function. And the third announcement after the lunch break. And the third lunch will be served after that, so valedictory will be before that. And the third important announcement is again for PG students. With the permission from AY Aurangabad organizing body, we are offering for PGs from Marathwada, all PG students, 15 days free observation government cancer hospital with due permission from their HOD and dean. So as per their convenience, they can come, they can inform us, and we'll arrange from our side. So these are few announcements. So thank you. Over to next section, Dr. Atul.
Now we are going to start the next session. That's an interdisciplinary talk session. Okay. Before that, there is an announcement from the MENCON team. I request Dr. Gaikwad sir to come on the dais. For the next session, I request Dr. Gaurav Patel to chair the session to please come on the dais. Dr. Shekhar Gobre sir to come on the dais.
Hello.
And Dr. Parag Doifude sir
Hello.
to be on the dais as a chairperson.
Me, Dr. Gajanan Moniraj Kashid, Organizing Secretary of MENCON 2022. मी सगळ्यांना पिलग्रिम सेंटर शिर्डीला मेनकॉन 2022 साठी 2, 3, 4 डिसेंबरला इन्व्हाइट करतो. माझं शॉर्ट इंट्रोडक्शन म्हणजे माझी जन्मभूमी जरी अहमदनगर असली तरी माझं शिक्षण बऱ्यापैकी सगळं मराठवाड्यातच झालेलं आहे. 11वी 12वी लातूर, MBBS अंबेजोगाई, MBBS नांदेड आणि MS अंबेजोगाई. तर मेनकॉन 2022 अकॅडमिक सेशन आणि माहोल बँक्वेटसाठी मी सर्वांना इन्व्हाइट करतो.
Venue is also very nice. Menu will be nice, and scientific academic sections will be very interactive. You all are cordially invited.
सेक्शनसाठी जास्तीत जास्त पेपर्स यायला पाहिजे. कॉन्फरन्स एकदम चांगली आणि जोरात होणार आहे. सगळ्यांनी प्लीज रजिस्टर करा आणि 2, 3, 4 डिसेंबरला येण्यासाठी. कोणाच्या जर काही अनयुज्युअल रेअर केसेस असतील तर सोयीसाठी तेही पाठवून द्यावं. थँक्यू.
Okay. Now we are going to start the next session. I invite on the stage our first speaker, Dr. Prakash Devde sir. He is going to give us talk on role of systemic chemotherapy in head and neck cancer region. Slide please. Slide. So Dr. Prakash Devde sir is a senior medical and hemato-oncologist. He is from the Mumbai Onco Care, the center at Aurangabad, and he is working as a consultant medical oncologist and head of medical oncology department in International Oncology Services Private Limited in association with Seth Nandalal Dhoot Hospital. And now sir, you can start your. Thank you very much.
Thank you for the introduction.
Timer la.
Thanks organizing team for having me here. So I made this talk considering or keeping in mind that what ENT surgeons have a role or especially in head neck cancer, mainly in prevention, early detection, and what basics you need to understand about systemic therapy in a head neck cancer. So I call it as systemic therapy because previously it was chemotherapy. Now systemic therapy, it includes chemotherapy, targeted therapy, immunotherapy, and systemic means in system, so it is in circulatory system. So it is any therapy which is given IV, oral, subcutaneous, which is going into the circulatory system. It's called systemic therapy, and it is a like broad terminology now in use. rather than the only chemotherapy. So just brushing the basics, this is the anatomy of head neck, because we should know the sites and subsites in head neck, because all the guidelines are they are based on the type or a site, and also the site of the disease also important, because all etiopathogenesis, treatment, biology of the disease is different as per the site. Even etiopathogenesis like HPV, tobacco, these are as per the sites different. So basically oral cavity, pharynx, larynx, nasal cavity, paranasal sinuses, salivary glands, these are the subsites. And in oral cavity, mucosa of the lip, floor of mouth, oral tongue, alveolar ridge, RMT, hard palate and buccal mucosa is included. And then oropharynx, it is a soft palate, tonsil, posterior lateral pharyngeal walls and base of tongue. And as a hypopharynx, it is pyriform fossa, lateral posterior hypopharyngeal walls and postcricoid region. And coming to the histologies, because majority are squamous cell carcinoma, but we have to keep in mind that there are other histologies where treatment or treatment algorithm is different, especially sarcoma, lymphoma, where upfront surgery may not be appropriate and there needed neoadjuvant chemotherapy, or only chemotherapy as a treatment and surgery is not needed. Here comes the role of ENT surgeons, because they come to you first, and it is for oral cavity cancers where early detection is very easy, because it is all lesions are visible, felt, and we can diagnose malignant, pre-malignant lesions early. So this is a Indian data. It was published in Lancet 2005, that how we can decrease the oral cancer mortality. And it has, that paper showed that there is a potential of preventing at least 37,000 oral cancer deaths with screening of oral cancer. Now coming to the concepts in oral cancer management. Basically in all cancer, not only in oral cancer, the usually flow chart is like we diagnose the disease, we stage the disease, we then decide the intent of therapy, whether it is a curative or palliative, or mainly in curative we go ahead. And if it is a recurrent, then again intent is very important, because many of the targeted immuno, they are in non-curative setting rather than the downsizing disease and all. So now systemic therapy, especially used in the setting like after surgery with as a post-op chemo with adjuvant RT, where surgery is not possible, that is larynx, nasopharynx with definitive radiotherapy as an induction chemotherapy. So downsize the disease before any definitive therapy like surgery, radiation or definitive CTRT. There is an induction chemotherapy, or called as neoadjuvant chemotherapy, that is especially useful in only nasopharynx and larynx and some selected cases of hypopharynx. There is no role of any induction chemotherapy in oropharynx, buccal mucosa, locally advanced. So there comes the surgery post-op CTRT only. As an adjuvant chemo, where there is a disease in remission, like post-surgery, there is no evidence of disease, and we give chemo to prevent recurrence of disease. So there post-op CTRT, afterwards also we give adjuvant chemotherapy, that is in nasopharynx. That is a standard of care now in locally advanced nasopharyngeal cancer, stage 2A up to 4. And lastly, in recurrent metastatic setting, as a palliative chemotherapy, targeted therapy like cetuximab, nimotuzumab, immunotherapy like pembrolizumab, nivolumab, these are in recurrent metastatic setting. So coming to role as a post-op CTRT, there is a data show that, to show that there is a overall survival advantage of adding chemotherapy with RT after definitive surgery. And there are only 2 indications where you have to add chemotherapy with RT, that is extranodal extension and positive surgical margin. The other indications, there is less data, and we have to personalize therapy accordingly. and I call it as relative indications, because if there are multiple positive nodes, perineural invasion, lymphovascular invasion, T3, T4 tumors, and in oral cavity oropharynx, positive level 4 or 5 nodes. So these are here we can give or avoid chemotherapy in selected cases. So this is the right hand side. This is a NCCN guideline, that is American guidelines, where cisplatin is the only chemotherapy we give as a post-op therapy, and that too 3 weekly chemotherapies. And where cisplatin is not eligible patients, there docetaxel and cetuximab, that is targeted therapy, has a lower, but it is inferior to cisplatin. Now coming to the definitive CTRT in larynx, nasopharynx, hypopharynx, there are many other options with RT, but high dose cisplatin, that is 100 per meter square every 3 weeks, up to 3 doses, that is the standard with RT in definitive CTRT. Other options are weekly cisplatin or weekly cetuximab or weekly cisplatin cetuximab, but they are not recommended as of now. So we practically use cisplatin high dose in fit patient, young patient, and majority of patient, and then weekly cisplatin where patient is older or there is a relative indication of giving chemotherapy as part of definitive CTRT. So this is just to show that there are various options of chemotherapy with definitive CTRT. There are less options in post-op CTRT. There is cisplatin is only used, but with definitive CTRT there are various options, but high dose cisplatin is the main crux. So this slide is just to show there nasopharyngeal cancer and non-nasopharyngeal cancer, where definitive CTRT, what is the difference, that in non-nasopharyngeal cancers we have these many options, but again in nasopharyngeal systemic CTRT there is data of only cisplatin with RT and followed by adjuvant chemotherapy, as I earlier said. Now coming to the induction chemo, that is before any definitive therapy like surgery, RT, and it is mainly used in larynx, nasopharynx. Chemotherapy of choice, TPF docetaxel, has been shown better than double agent chemotherapy, and in nasopharyngeal cancer this chemotherapy is different, that is standard is cisplatin gemcitabine. So it is not for all head neck cancer, neoadjuvant chemotherapy is same. There is no data in CA oropharynx as an induction chemotherapy, and at other sites you can see the trial data of RTOG 9111 trial, where there is a selected cases of hypopharyngeal cancers, there is a improvement with induction chemotherapy. And the pros and cons of chemotherapy if you give neoadjuvant is that if there is a radiological CR like nasopharynx, larynx, if there is a radiological CR post induction, then only RT can be considered. So these are pros, and cons are if you give neoadjuvant chemotherapy, another pro is you can see the biology of disease. If you give neoadjuvant chemotherapy and patient progresses, the morbid surgery can be avoided. But with neoadjuvant chemotherapy, some fitness comes down, and many a times the definitive therapy, that is surgery, radiation, the fitness decreases, and full therapy of definitive CTRT patient may not complete the definitive therapy. So we have to keep in mind while giving neoadjuvant chemotherapy. As adjuvant chemotherapy, so after say CA nasopharynx, we are given usually in stage 2 4A, there is a role of neoadjuvant chemotherapy, that is before any starting radiation chemotherapy we give 2 to 3 cycles of chemotherapy, TPF docetaxel or cisplatin nasopharynx, as I said cisplatin gemcitabine preferred. So if you not give neoadjuvant chemotherapy and CTRT has been received, there we give adjuvant chemotherapy, and that is the outcome, and outcome data is robust with meta-analysis of 20 trials with more than 5,000 patients. there is a role of addition of adjuvant chemotherapy. So this is my, I think, last slide. In a recurrent metastatic setting, as I said, non-nasopharyngeal cancer, we have to see first intent. If it is a non-curative, we are not going for surgery, radiation as a curative measure. It is then comes the role of pembrolizumab, that is immunotherapy. Now, the first line and first preference is immunotherapy with chemotherapy. If it is not fit for chemotherapy, then if it is a marker for immunotherapy PD-L1, if it is more than 1% PD-L1, then we can give even immunotherapy single agents. Other chemotherapy options are there. Anti-EGFR antibodies, that is cetuximab. These are the option in non-curative setting as a recurrent metastasis. In CA nasopharynx, as I said, cisplatin, gemcitabine, even in recurrent setting is preferred. So to summarize, head neck cancer sites are important to have because it have different biology, pathogens and treatment, and also have to identify histologists to avoid inappropriate upfront surgeries. ENT surgeons have a role in tobacco cessation counseling, main early detection, main because it is the oral cavity cancers are major in India. Management, multimodal, needing surgical oncology, medical oncology, radiation oncology, plastic surgeon, rehabilitation specialty, extra. And there is a role of neoadjuvant chemo in nasopharynx, larynx and some hypopharynx, and not in other cases. And there is a role of adjuvant chemo in nasopharynx. So in again recurrent metastatic setting, intent to be decided, because accordingly we can push patient for immunotherapy, target therapy, as that can be planned in non-curative setting only and not for downsizing. Thank you.
Thank you very much, sir. Topic is open for discussion. Okay. So now I request Dr. Ritesh Bhagyavan, Secretary of AOI Aurangabad, to felicitate Dr. Prakash Devde, sir. Now I want to invite on the stage Dr. Amol Ubale, the radiation oncologist, to present his talk on role of radiation therapy in head and neck cancer. Slide, please. Dr. Amol Ubale is a senior consultant and head radiation oncology in Seth Nandalal Dhuth Hospital. And we all know him. Since last 12 years, he is doing an excellent job. And the dais is yours, sir. Now.
Okay. Good morning, all. And thank you organizers for this opportunity. So today we are going to discuss role of radiation oncology in head and neck cancers. So to start with epidemiology, I'll run very fast through these initial slides. These are the 6 most common cancers worldwide, most common cancers in developing countries, most common cancer in males in India, Globocon 2020. Because as compared to lung and prostate and breast, lung and prostate, Globocon 2020 has collected various sites of head and neck cancers together, means like tongue, oropharynx, buccal mucus and all. 5th most common cancer of females in India. More than 95% cancers of head and neck are squamous cell. Then common sites are oral cavity, oropharynx, larynx and hypopharynx. And risk factors we all know, tobacco and betel nut and all. HPV, where do we stand as of now? Overall global prevalence of HPV is around 50%, and in India it is slight greater. In Asia it's around 33%. So in India it ranges from 33% in eastern region to 67% in South India, 15% in Western India, And this prevalence of HPV 6, 11, 16 and 18 are respectively like 13%, 20%, 42% and 47%. So why HPV is important? Because recently in US and all, we have seen that a lot of oropharyngeal cancers are related with the HPV. So that's why it is very much in discussion right now. So HPV 16 is most common type, followed by HPV 18. So these are the differences between HPV positive and negative, where we all know. So I'll run through this. So what about vaccination status of HPV? So still there is no very robust data evidence, but CDC has recently claimed that if HPV vaccination is working nicely in gynecological cancers like CA cervix and all, so these can be beneficial in oropharyngeal cancers as well, but still not very clarity on that. So site-wise distribution is like this. Oral cavity, pharynx, larynx, nose, PNS and all. Then this is our own data from Seth Nandlal Dhuth Hospital. This data we have collected till 30th September 2022. So we have recently completed 5,000 patients in our institute from April to 2015 to September 2022. And out of that we have collected this data which is in front of you all. So we can see clearly the male and female distribution is around males 78% and female it is 22%. So we'll go through the guidelines for the management of head and neck cancers. So first we have to do the staging. Staging, it includes clinical examination plus imaging. It is the first and very important step in the management. In imaging, it is CT scan, or in like some sites of nasopharynx or PNS, we do MRIs also. For oral cavity, like for the treatment part, if early disease is there, surgery is the main treatment modality, which is followed by adjuvant CT-RT. Sometimes only adjuvant radiation is required, sometimes both of these things are required, we'll see in further slides, or sometimes surgery is also enough if it is very early stage disease. Like in loco-regionally advanced cancers which are borderline resectable, as Dr. Prakash sir said, that neoadjuvant chemotherapy helps in these cancers, which is then followed by surgery and then followed by plus minus RT plus minus concurrent chemotherapy. And in very loco-regionally advanced cancers, like which are completely unresectable, T4B disease, so in that patients we have to go for definitive chemoradiation as a main treatment. In nasopharynx, all stages except 4C, definitive CT-RT is the main treatment. For oropharyngeal cancers, all stages except 4C, definitive CT-RT is the main treatment. Larynx, here now little bit discussion can be done. Like stage 1 to 3, definitive CT-RT, that is chemoradiation, can be tried against the surgery, because larynx preservation RT really helps for the preservation of larynx. If it fails, then salvage surgery is always the option for local recurrence and all. And in stage 4A, 4B, total laryngectomy plus bilateral MND plus minus adjuvant RT or CC concurrent chemotherapy is the treatment. So this I have put this slide for all the consultants, and if PG students are there, they can go through this NCCN guidelines. Very clear and very nice explanation and guidelines are given in this. So HPR, what to look for? This is very important when we when you operate the patient of head and neck cancer like CA buccal mucosa or CA tongue. What things you have to see in the histopathology, because a lot of pathologists are not very well versed with reporting of oncology cases. So you should ask them the following points. These are the very important compulsory points to see for. First is histology. Second, histology means like squamous or other like adeno or something. Then differentiation grade, like grade 1, grade 2, grade 3. Tumor size, that is for T staging. Depth of invasion, this is very important and recently come up criteria. Please mind it that it is not tumor thickness, it is depth of invasion. Both things are different. Many pathologists get confused between depth of invasion and tumor thickness. So depth of invasion is very important, not tumor thickness. Then perineural invasion, lymphovascular emboli, then worst pattern of invasion like WPOI. This is also recently come up criteria. It is a criteria which is related with the mortality of head and neck cancers. If it is more, the score is more like around 4 or 5, then the mortality is more. Margin status, it is very important. like closest margin you should know, that should be clearly reported in the report, which is the closest margin, like anterior, posterior, lateral, whatever it may be. But how much millimeter it is away from the cut margin, that is very important thing. Then nodal status. What things we have to see? Ratio, levels. I have highlighted levels because this thing is very commonly missing in a few of the centers. They do very well, but a lot of reports we see, levels are not mentioned properly in the histopathology report. Why it is important? Because while radiating the patient in adjuvant setting, if the levels are not mentioned, we most likely we have to treat whole the neck, which is very toxic to the patient. So if surgeon has histopathologist mentions which level is positive, which level nodes are positive and which are not, then it is very easy for radiation oncologist to radiate that particular level and give very elective dose to the other levels. And then extranodal extension is also very important criteria. So what does clear margin indicates? Clear margin means the margin which is more than 5 mm. That is a very simple thing. Closed margins 2 to 5 mm, and positive margin is at like carcinoma in situ or invasive carcinoma at the margin. But the last few lines are very important, that carcinoma in situ, which is present on the margin, is not an indication for like concurrent chemotherapy to be added to the radiation therapy. Revision surgery, if can be done, that is a good thing, where frozen comes in the place. So indications for adjuvant RT and CT, like PT3 primary, tumor size more than 4 centimeter, T4 primary, node positive disease, N2, N3 disease, PN1 disease in level 4 and 5, PNI, LV, positive margins, perinodal extension. These are all indications for adjuvant RT. But whether to use adjuvant concurrent chemotherapy, we have to see what to be done. So adjuvant RT only in above these indications, and we have to add concurrent chemotherapy in these following 2 indications. So if you can keep in mind these 2 indications only, like positive margins and extranodal extension, these are the very robust guidelines that we have to add concurrent chemotherapy in these 2 indications. So these are the 2 main trials. So what are the gray areas? Like closed margins, depth of invasion, N1 status in any level, young age, HPV status. These are little gray areas as of now. So in closed margins, like 2 to 5 mm adjuvant, this adverse prognostic factor, adjuvant RT is preferred even in T1 or T2 disease also, and high dose should be given to the post-op bed as a boost. Depth of invasion 4 mm or more, adjuvant RT should be preferred, especially in CA tongue cases. CA tongue is the very worst prognostic disease. We have seen like T1 disease, T1 CA tongue patients not given RT with 4 mm of depth of invasion have failed locally and regionally also in nodes. So we can skip in the buccal mucosa, alveolus and other parts, but CA tongue, one should be very cautious while giving adjuvant treatment. PN1 disease, stage 3 disease, N1 means it goes in the stage 3, adjuvant RT should be given. Young age, adjuvant RT should be preferred. HPV status, radiation dose de-escalation, mind me, de-escalation can be safely done. So what is radiation therapy? Now we will come to the core subject. Radiation therapy is like treatment of disease with ionizing radiation. So this was the old cobalt machine. This is the new high-end linear accelerator which we have at Seth Nandlal Dhuth Hospital, Clinic IX. So how it is done? This is the very long schematic diagram, so I'll skip this part. This is very technical part. This is a simulation part which we do in the initial part. Face mask is prepared of the patient and immobilization is done. Then CT scan is obtained for transferring the data. Then on computers, all planning process is done. This organ delineation and organ at risk delineation, target delineation is done. These are the RTOG guidelines for that. These are just to show how it is done. This is the DRR, digitally reconstructed images. We can see the short neck and long neck. It also plays a vital role in the planning. Location of rallings, we can see it is different in both the necks. So shoulder come in the place in short neck patients. So it is very difficult to do the planning with simple techniques. So advanced techniques comes in play in these patients. Like this, we have to contour all the salivary glands and the spinal cord and other oral cavity areas. We have to save them, and we have to give radiation dose to the main structure, like target like say larynx or whatever, oropharynx or whatever. So this is the radiation zone which is in blue, which is designed to cover cancer and nodes, and the normal structures are avoided from this radiation zone as much as possible. So these are the, I'll take few more minutes. These are the radiation dose guidelines, how much dose has to be given, like post-operative also 60 gray or 60 gray is given around. So these are the radiation techniques like 2D planning, 3D planning and IMRT. Nowadays new techniques have also come like rapid arc or VMAT. So what is the difference between these things? The more the advanced technique, then you get fine tuning in the planning. You get very targeted dose to the target, to the primary or to the tumor, and the organs which are nearby or the normal tissues are spared. So it decreases toxicity. This is a conventional 2D planning. This is IGRT. IMRT side effects and IMRT and side effects. Xerostomia is the most common side effect. You all might be knowing passport trial. So this trial has shown that with IMRT we can reduce xerostomia, that is dryness of mouth, very significantly. So IMRT is now the main modality of radiation treatment in head and neck cancers. So I'll skip the videos as the time is running short. This is just the planning images. I'll just touch this topic. What is adaptive radiotherapy? When we see that little big nodes are there and neoadjuvant chemotherapy is there, unresectable disease is there in head neck, we start with definitive radiation and chemotherapy. A lot of times nodes shrink. So after 10 or 15 fractions, if node is shrinking, then we have to do replanning of that patient so that that node is properly covered and normal tissue should not come in the target. So that is called as adaptive radiation therapy. So you can see here, this in the first image, the node is big. After 15 fraction RT, shrinkage of node is there. So I'll skip this chemotherapy part, it's already covered. Now few more slides. These are our results. CLF tonsil T2N0 disease. Prior to RT, you can see the disease clearly. Post RT 1 month, the disease has already completely gone. Then NHL DLBCL patient, post chemotherapy patient, no response to left neck node with chemotherapy. Radical RT is given, and within 15 days, node completely disappeared. So lymphomas and all these things, these melt with the radiation completely. So they see oropharynx patient, unresectable patient, given neoadjuvant chemotherapy, then palliative RT is given to the neck. You can see how it regressed. You are not able to see the posterior part of the neck in the first image, but after last day of RT and 2 weeks post RT, you can clearly see the shrinkage of the disease. These are the recent images taken 2 days back. CA larynx patient on PET CT. We can clearly see that there is a complete response to the treatment.
We have to stop,
Last 1 or 2 slides. CA right tonsil. So take home message. This is last slide. Radiotherapy has evolved last 5 to 10 years. Multimodal management is the main key. Radiotherapy is not a substitute for inadequate surgery. Outcomes are very poor. So this is very important point. Margins should be very clear. Precision radiotherapy is a game changer, and least toxicities are very important thing with the advanced radiation techniques. So recently we have completed 5,000 patients at our center with very good results, and I thank you all for patient listening. I have to rush through a lot of slides because of the time constraints. So if any questions are there, please. Thank you so much.
An excellent presentation, but needs to be a little bit shrinked up.
Yeah,
okay.
Too much. Any questions, please? Okay.
So I call upon stage Dr. Sambhaji Chintale to felicitate Dr. Amol Ubale.
फ्रीज करून टाकते. सर बोलो ना. हाँ लगेगा.
Yeah, fine. Okay.
Slide changer आया.
So our next speaker is a well-known plastic surgeon of Aurangabad and Marathwada. I would like to introduce Dr. Jiten Kulkarni sir. He is a senior plastic surgeon from Aurangabad, and he is associate professor in the MGM Medical College, Aurangabad. His special area of interest are rhinoplasty, microvascular surgery, and he's trained at JJ Hospital, Mumbai since 1995 to 97. He's honorary secretary of Maharashtra Association of Plastic Surgeons. He's an executive committee member of Association of Plastic Surgeons of India, Indian Society of Surgery of Hand, and reviewer of Indian Journal of Plastic Surgery. So I welcome sir, and now the dais is yours.
Thank you, Dr. Atul. At the outset, I would like to thank the organizing committee for giving me an opportunity. Respected seniors and my dear colleagues, this topic of rhinoplasty is very close to my heart because we have been associated with Dr. Baman Dawar, who was my teacher at the GT hospital and involved in rhinoplasty. So I would like to clarify at the outset that I do not do septal surgeries. All my septal surgeries are done by my ENT colleagues. Because whenever we go for a presentation, there are two things which are coming to someone's mind. Why is he here and why we are here? So I would like to clarify that I have been greatly benefited by my ENT colleagues, because had they not referred me cases, I would not have progressed to this. And how you have benefited, I think I leave it to you, but I have made my point clear. Mr. Wright has rightly pointed out that form and function should be one, joined in a spiritual union. In the sense that septoplasty and rhinoplasty go hand in hand is clarified by this. So we been doing septoplasties and to improve the functional part, but it is essential that we correct the external nasal deviation at the same time, which is in turn a vital step in rhinoplasty. There are some cases with no functional problems and we undertake only rhinoplasty, but then we need a graft from the septum, or unless we correct the deviation in the septum, with the rhinoplasty will not have any final result. The era of structural preservation rhinoplasty, a hybrid approach. So this is a recent article which emphasizes that we have to do the functional component and the aesthetic component together. So the radical change has occurred over the years in the rhinoplasty, that we are more concentrating on minimalistic approach and getting the best out of the patient and trying to meet the expectations. This shows the spectrum of various deformities of the septum and the cartilages as well as the bony component, and we need to address in a systematic manner in a millimeter wise fashion. Unless we do that, we will not have the desired result. So the problems which are encountered are there are complex deviation of septum. The patients which come to us, most of them have caudal dislocation. Some cases give history of post-trauma, but otherwise we may miss out if it's very childhood. Thick skin is another problem with our area. Bulbous tips in some cases, and previously operated as we keep doing more cases. This presentation I have made is personalized for especially the postgraduate students, which I feel are stuck somewhere. But then anyway, we can convey them. So time and again, most important aspect in rhinoplasty is a detailed history and patient expectation. Very, very important. So is clinical assessment and counseling. We have to get into what is in his head and make it crystal clear what you can give and what you cannot give. If he goes to some other colleague, it's fine, but at least you have clarified. And the most important part is once he is with us, we tell that the ENT part is not done by me and it is done by my ENT colleague. So this is clarified at the first consultation. There is no grudge that it's a backdoor entry for a ENT colleague. It's all crystal clear and they go for a formal consultation, because there are some things which are beyond my scope and they are well tackled, like doing a CT PNS or not, doing endoscopy along with it, maybe a minimal phase is a decision by the ENT colleague. Preoperative photographs and planning. I think this is very vital that you take the photographs, do a study and then finalize your plan. Written plan has to be displayed in the theatre, because we are in a hurry and sometimes we may miss which case we have seen in the last week, and some subtle point which is very particular for the patient may be lost. So there is no harm in spending a few minutes and writing it down. So the ENT colleague has developed sort of a feeling that why you are doing this. So there is a cross questioning and we respect that he is with us. The plan is always confirmed by the ENT colleague. Magnification, I do not need to emphasize to this August gathering because you are all the time in operating under magnification, but it has given immense help to us when we are doing the open rhinoplasty. And the execution of all steps have to be done as per the plan. If there is a deviation, it means either there is a problem in the technicality or there is some error which has been committed by the operating surgeon. And the radical approach will only give the best result. The technique, whenever we are explaining or going to show, has to be reproducible. It should not be something unique that no one else can replicate it. Because this is an era of exchange of information and we cannot hold to ourselves what we are doing. And everyone, like we have 10 commandments in plastic surgery, thou shall have your own plan. So it's a sort of, it is a signature plan. You may do some changes as per the patient demands and expectations. And there should not be an operated look for the patient. And we anticipate long-term results when we touch the patient. So these are the 4 S which are very important. We retain, reposit, reshape and reinforce. Now this spectrum, as you can point out, that you cannot solve by only addressing the septum. Sometimes the access itself is very difficult, the formal access. So we need to do a roof access. And here I think the importance of team approach which gives reproducible and consistent results. The era of Gubish has revolutionized rhinoplasty understanding and hence the execution. So the direct visualization, use of various grafts with complex terminologies, and it took quite some time to get used to the terminology. So more important is near normal restoration of the airway and finesse in addressing the aesthetic issues. And we got nearly a good volume of predictable results. So there are newer techniques which keep coming and going, and each time we go for a meeting or a workshop, some things keep coming and we try experimenting and we keep swinging. But for the postgraduate, I think we give a stepwise approach. Open rhinoplasty is now the gold standard, where you may harvest keeping a L strut, you may do modified extracorporeal or a complete extracorporeal. Now here a word of caution, whenever a novice is attempting extracorporeal, it has to be done very judiciously. First priority, airway passage restoration, the osteotomies, various grafts which are mentioned, batten, tape, the LR rim, septal extensions. Then we have extended spreader. Conca I use quite routinely if there is a scarcity. And we tell the patient and write a note that 30% may need a touch-up surgery, even though we may be doing maybe around 5%. But it's better that we commit. So it is known as under promise and over deliver. So there is no harm in saying that our results are this. This is an inverted V which is to be placed at the columnar waist. The V should be at the columnar waist and bilateral rim incisions. We do a lot of infiltration with Hollandaise and xylocaine adrenaline. This is a very important step. Bipolar coagulation of this artery is very important. Otherwise you get oozing throughout the procedure. Trimming of the caudal, the cephalic end. The caudal end is to be done very judiciously. Cephalic trimming of the lower lateral cartilage. Again, we have to weigh whether we want to fold it or you want to trim it. Then rasping the hump is conservative. You can keep rasping it. Shaving the cartilaginous hump is important. And the tunnels for the spreader grafts. So this is the first slide showing that the lower lateral cephalic trim and then infolding has been done. And the second is the excision of the very thick lower lateral cartilages. Now this shows the rasp with the bony dust, and you can rasp till you have a good outcome. This is the roof access where you go sequentially, and you can use 15 or 11 number with this tunnel going in on both sides, mucoperichondrial elevated and symmetrical elevation on both the sides. The excision of the septum as per your plan, and see the type of deviation which you cannot achieve straightening only by scoring. So here, this case, we are preserving the L strut. Now this is the harvest of the remaining septal graft. This is extracorporeal, where we have excised the entire septum, and then L strut with the spreader graft assembly will be put in again. Now this is a caudal end which was totally deviated, and this patient we have put the septal extension graft along with the extended spreader graft, and this assembly is now sutured with 5O PDS. 3 sutures of 5O PDS will stabilize to the upper lateral cartilage. Now this is the external osteotomy, low to low and transverse, to shift the bones medially, and you can appreciate it's in a midline. This is correction of the caudal dislocation, which is very important, that if it's a excess or it's deviated. And the patients are more concerned about looking in the mirror, and the relatives point out, Sahib, hey, diste. It means you have not done a good job. So I think they are already watching us and in a silent zone. Now this is the columella strut or fixation of the extended spreader grafts, putting the dorsal grafts and the shield, the peg or the sheen graft for the tip. Drilling hole in the anterior nasal spine has given more stability. You can fix with a 5O PDS the assembly which you have put in. Some people ask what would be the scar like. So if you have done a good job and done a good closure with 5O PDS and 6O rapid, after 3 to 4 months, it's hardly noticeable. Now this is the type of dressings and plaster we give. I'll show 1 or 2 representative cases. This is before and after. Before, this is intra-op, the assembly put in, and this is the on-table result. This is the pre and post-op, worm's eye view, the lateral view, the other lateral view. This is a cleft lip nose, where you can see there is a room for doing much more, and these patients may need touch-up surgeries. Here we have flipped from the non-cleft to the cleft side to increase the thickness of the ala, and we have done the alar base augmentation using the cartilage grafts, apart from osteotomy and the other work. This is pre and post, the other lateral. Now this is another case, pre and post, oblique, the lateral, the other lateral. Now these are the sequences in which we have already seen them. This was a bulky nose with deviated septum. Here we have done the trimming. This is the worm's eye view, the lateral, the other lateral, the aerial view. And last meeting, I thank Dr. Bilgi for giving us opportunity to use the VTOM. So we were really interested in knowing what this VTOM or whatever it is. So we tried it out, and this was actually a recording of the picture. Actual recording we are yet to get, but I think this is good for demonstration purposes. And the last meeting we had in Nagpur was really fantastically organized by Kshitij and team, and the vision which obstructs because of our operating hand is totally very clean. So this was a good improvement. So what we do is, when we do marathon running or we do any sports activity which I am involved, it's not about where you reach, how many gold medals you get. So it's about the journey with my ENT colleagues over the last 25 years. And we have seen that that journey is important. So cases will keep coming and going, but special thanks to list which most of them I feel are in the hall, and I really thank them from the bottom of my heart for giving me an opportunity. So they have proved that together we can, and thank you for patient listening.
Excellent presentation, sir.
If there are any questions.
Any questions? House is open. Okay. Now I invite Dr. Shrikant Sahuji, sir, President AOI, to felicitate Dr. Jiten Kulkarni, sir.
Thank you.
Now I invite on the stage Dr. Viraj Burgaonkar sir. He is an oncosurgeon and he would give his talk on head and neck cancers emerging trend. Slide please. Raudin. Dr. Vijay Burgaonkar sir he has done his MBBS from Government Medical College and then done his general surgery from Udaipur, and he has done his MCH surgical oncology from Tata Memorial Hospital. He is presently working at Krupamai Hospital as Director Oncology Department and also working as consultant Seth Nandalal Doodh Hospital. He is the first qualified surgical oncologist of the region. His area of interest are breast, GI1, then head and neck and thoracic cancers, and he has multiple publications in various international and Indian journals. So welcome sir, the dais is yours.
Good afternoon. I thank organizing team for giving me this opportunity and rest of all you people who are starving, I think. So the topic is quite difficult one, and head and neck, there are fairly any emerging trends, and it is more like a circle where things come back to the basics. And I have touched the topics which my predecessors like Prakash and Amol have not touched. So it's little bit a touch and go for me. So this is my new venture. I like to take this opportunity to introduce all. This is our new venture. We have started this hospital at Krupamai at Baba Petrol Pump, and we are with this next generation linear accelerator with all these gizmos like IMRT, HRT, Rapid Arc and SBRT and high dose delivery. So 50 to 60% of our load is head and neck cancers. So coming to the introduction, we all know oral cancers are common. They are the major burden. Patients are coming at third and fourth stage, and we are left with limited treatment options, and they are mostly the low income population. Considering the ICMR demographics, which have been reported all across India, West, and it's everywhere in India, but mostly the ages are 60 to 69, but I think in our practice what we see that the ages are between 30 to 40, and this is more because of the chewing of gutka. So why this head and neck cancer is so troublesome for surgeons, medical oncologists and radiation oncologists, and especially this medical oncologist one, because they are trying to steal all the diseases from our pocket. Because there are a lot of mutations. The head and neck cancer is a most heterogeneously mutated malignancy where you cannot treat it by one targeted drug or something. So it has to be physically excised. A normal mucosa to hyperplasia, dysplasia, carcinoma in situ and invasive malignancies is a routine event, but this can be done in a one go or in a temporal fashion. So the mutations play a major role in these malignancies, and there are all sorts of mutations you see there. Worldwide, malignancies are now discussed with HPV positive versus HPV negative. Because if you see, if it is a HPV positive, there are only two mutations, P53 and RB1, where radiation and chemotherapy play a vital role in curative of these diseases. These patients get cured, they get a better long-term survival and better outcome. Unfortunately, in India, most of our patients are using all these things like areca nut, smokeless tobacco, smoked tobacco, alcohol, leading to a lot of DNA damage at multiple levels and multiple mutations, deletions and amplifications. Coming to some pre-malignant oral cavity conditions, as all of us are frequently seeing these patients in oral cavity malignancies like leukoplakias, erythroplakias, submucous fibrosis. These are all the forerunners of the malignancy, we all know. So, what are the current guidelines for handling these pre-malignant lesions? First and foremost is biopsy is mandatory, that what it is, not merely by a clinical examination. You should do a biopsy and prove what it is. Because if unfortunately it's a dysplasia, then it is recommended that you excise the 5 mm mucosa all around it. If it is carcinoma situ, then go for a proper wide local excision. Now, type of excision as per the literature is your own discretion. You can do it by knife, you can do it by carbon dioxide laser, whatever resources you have, both have equal outcome. There is no superiority to other. The only superiority has been found to be a CO2 laser ablation or excision happen to have less blood during the surgery. Overall, the recurrence rate with all the modalities is 34.4%. We are fortunately to have this luminous laser with us, where we routinely do these leukoplakias. And sorry. So basically, we have seen this excision of leukoplakias has led to more wide excisions. So the leukoplakias and especially these leukoplakias, they are on the field, like field cancerization all over the tongue. So excising them would lead to bigger defects. So we do a surface ablation and we are finding it better results. Now coming to field cancerization, this was introduced by Slaughter in 1946 concept, was published in 53. What he said that it is the cancer formation is not an isolated event. It is because of the carcinogen and epithelium prolonged exposure. And there are now, it has been in Nature 2020, what we have got is a multifocal associated independent mutations around this. So they are ascertaining the facts given by the Mr. Slaughter that the tumor is because of field cancerization, and that is the major reason for recurrence after surgery, radiation, and it explains the second primaries, what we get often in head and neck cancers. So now coming to the margins, this is the most important thing we come across and what we have to do and how we define these margins. A surgical margin is a margin which is where your cautery or a knife touches the mucosa. So negative margin, what we aim for is more than 5 mm, close is 1 to 5, and margin less than 1 mm is considered as a positive margin. Margin less than 0.5 mm, pre-malignant lesion at your margin, carcinoma in situ or invasion are all considered positive margins. Now we do a fine excision most of the time and the pathologist reports that your margins are close. The most common thing leading to it is tumor shrinkage or specimen shrinkage after putting into the formalin. So a good amount of study done by it has concluded that even you have done a nice job, but when you send the specimen to the pathologist, it takes a time, 24 to 48 hours, it is in formalin, and 30% of the shrinkage happens. So even you aim for like negative margin of more than 5 mm, it has been now advised that all 3 dimensions at least go for 1 centimeter margin. So you have 30% shrinkage and your margins on report are reported properly. So how to handle these margins is you do a proper resection, proper orientation of the specimen, because most of the pathologists are not oriented, so orient them by inking, by suturing. As long as possible you have access, use frozen sections. If you don't have frozen sections, then interpret in histopathology. And if you have closed and involved margins, then these are the criteria for sending them for chemoradiation. And if you have a clear margin, then treat the patient accordingly what he has the disease. Even the T1 lesion with margin positive or closed margin, you should send them for chemoradiation. There is no point in revising the margins because these revised margins may not correlate with what is the exact status of the disease. So now this topic which point also I have selected is because of the N0 neck, because most of the elite class coming to us with the small tumors and N0 neck, and how to manage this N0. You operate and address the neck or no. So there was a study from TMH in 2008 which suggested that if you observe or operate, there is no difference in disease-free survival or overall survival benefit. But when they looked at it, the patients receiving radiation have been excluded. Then in 2015, they came up with the new publication and said that elective neck dissection in N0 neck, in T1 tumor or T2, whatever it is related with the long-term overall survival benefit. So if you have a N0 neck, your sonography is normal, it is better you do the neck dissection for the long-term overall survival benefit of the patient. And what has happened trickily, or God knows, is the tumor grade and PNI are the predictors for failure in the neck, not the tumor size and the depth of invasion as per the TMS study. Now something about this fancy technique of sentinel lymph node biopsy in head and neck cancer we do often in axilla. It helps to reduce the lymphangitis and axillary problems. The role in neck dissection and avoiding neck dissection is doubtful. It is established in only selected centers, happen to have lesser shoulder dysfunction and better quality of life. I personally feel like 2A, 2B are the only reason for where shoulder dysfunction happens, but it is up to a person to take this into practice or not. Now, oral cavity cancers operations are always mutilating long-term disability, speech, swallowing, and social issues. So they never come up with without a plastic surgeon standing behind. So we do all pedicle flaps, local flaps, but standard of care for all head and neck cancer reconstruction are microvascular flaps. So either you do a FRAF or free fibula or bulky reconstruction, ALT, whatever. So standard of care is free microvascular flaps because they are better cosmetic outcomes, better functional outcomes, but they are costly and the surgery is prolonged. So now coming to patient-specific prosthesis, these are the new technology which is coming in, that these are the 3D printed prosthesis coming with accurate measurements. They routinely require a flap to cover it. They are useful at times in elderly, but not much used for us because we always, when we do a major resection, the radiation is given so that prosthesis get failure. So failure chance in oncology is nearly around 30%. So that's how they get the CT scan, they modulate, they do a 3D printing, they give the prosthesis, and that prosthesis has been fixed inside. And mostly these have been used in nuclear cases nowadays, but oncology cases we hardly use them often. So now the other issue what we face nowadays is we've done a good job in 2013, and in 2022 patient is with ORN because of the radiation side effects. And these are the many cases we handle now of osteoradionecrosis, and most of them has to be dealt with microvascular free flap. Hyperbaric oxygens we try, but they fail miserably. So finally they have to go for the microvascular reconstructions. So this is the last short video which I will be playing. This was how you managed some complications. So there was an intractable left neck surgery was done outside, and there was an intractable chyle leak. Patient was pouring 1 liter. So 2-3 attempts in the neck were done. So control was not possible. So ultimately we have to go in and do the video assisted thoracoscopic surgery. So we dissected out the thoracic duct and ultimately we clipped it, and that is the final nail in the coffin. So if we clip it here, there is no chance that it will leak in the neck. So we have to use our other skills in management of head and neck cancers. So thank you. I thank not you but also my anesthetists who are there for 10-12 hours behind the scene, and our plastic surgeon standing behind my back at all odds and events. And we have a good team. We operate nearly 20 cases a month, and it's a high volume center with head and neck cancers. Thank you.
Excellent presentation, sir. The last video was very good.
Thank you.
Now the house is open for discussion.
I think everybody is hungry, so should rush.
So I invite on stage Dr. Ramesh Roiwal sir to felicitate Dr. Viraj Borgaonkar sir. Okay. So now I invite on stage Dr. Mayuri Bhagavan Pore for giving her lecture on anesthesia considerations in ENT surgery. Okay. She's MBBS and MD anesthesiology. She has done her fellowship in critical care in MGM Medical College. MD anesthesia from Sion Hospital, Mumbai, and she is practicing anesthesiology since last 7 years. Also, she is assistant professor in Department of Anesthesiology, MGM Medical College. Also she is my wife. Also. Yes.
So, good afternoon all. First of all, I would like to thank all the organizing committee, Ritesh sir and everybody in organizing committee, and my husband Dr. Atul Pore again to inviting me and to giving me this opportunity to present anesthesia in front of all the senior ENT surgeons here. So thank you so much everybody. Actually, anesthesia for ENT surgery, it's a huge topic. I try to cover it and made it precise as much as I can. Okay. So for the general anesthesia with spontaneous ventilation, apneic intermittent ventilation and jet ventilation. Patients with OSA, they are highly sensitive for the sedatives and opioids. So care should be taken in cases doing local anesthesia with mild sedation also. So mild sedation can be disastrous in these cases. So we have to take the care. Diabetic patient, perioperatively glycemic control has to be done. Head neck oncology itself is a huge topic, and in preoperative considerations in these cases we have to see the other comorbidities along with the malignancy, because these patients have the history of addiction to tobacco, alcohol, and the associated comorbidities because of these addictions are there. So we have to take care of all the comorbidities. These patients are anemic, malnutrition is common, and electrolyte abnormalities are also common in these patients. So preoperative optimization and correction of all these abnormalities should be done before taking these patients to the major surgery, major oncological surgeries. Okay, there may be a history of radiation which can be a problem for mask ventilation and intubation as well. Okay. So airway assessment is a must in any cases coming for the anesthesia, specifically in ENT surgeries, because in all the complications occurring in all surgical patients related to airway, the 40% incidence is with ENT cases. So it is seen during induction, during intubation, and during extubation, and in post-operative period as well. Okay. So we have to see the predictors of difficult mask ventilation and intubation, and preoperatively endoscopic airway evaluation can be done in cases where the airway can be a problem during induction. So these are different predictors. I will not go in details, but we have to assess preoperatively before inducing these patients. So preoperative endoscopic airway evaluation. Most of the ENT surgeons do the nasal endoscopy prior to the surgery to assess the airway, but not done by the anesthesiologist. But in cases when the airway is maybe the problem, in head neck onco cases, in these patients, airway can be assessed by preoperative endoscopy by the anesthesiologist and should be done with the ENT surgeons so as to assess the airway anatomy and dynamics before going and planning for the surgery. It's a better airway evaluation preoperatively. Okay. Pre-op optimization is a must because these patients may require intraoperative hypotension, induced hypotension in case of endoscopic surgeries, and major oncological surgeries also. So the control of blood pressure, control of blood sugar level preoperatively. Patients with upper respiratory tract infections are common because these patients are high risk for the intraoperative and postoperative airway complications. So they should be treated prior to the surgery. In OSA patients, yes, they can come for the OSA surgeries or non-OSA surgeries, any surgery. So preoperatively optimization and using CPAP preoperatively can be a beneficial to avoid post-operative airway collapse during recovery from the anesthesia. Okay, they are more prone for the airway collapse and post-operative airway obstruction. So it can be used preoperatively and after extubation also in the post-operative period. Surgical considerations, airway has to be managed and reviewed, planned before the surgery with the help of imaging and the endoscopy. Airway device that is to be used during the surgery. Route of intubation, there may be a need for the nasal intubation, oral intubation, or the surgical airway. If the head neck, if the oral malignancy is huge enough that it is not possible to intubate the patient, preoperatively planned surgical airway is an option. Okay, ventilation technique, yes, it can be a spontaneous ventilation, controlled ventilation, jet ventilation, apneic ventilation. So different modalities are available for the ventilation also in these cases, according to the surgery, according to the plan of the procedure what we are going to do. So we have to plan everything beforehand, and backup strategy should be ready, available at any time, because these can be a catastrophe during and post-operatively also. It is a shared airway with ENT surgeon and the anesthesiologist. Once we induce the patient and intubate the patient, it is not accessible to us. So we have to keep everything properly planned and adequately secured. ET tube should be properly secured, and the circuit should not come in the way of the surgeon, because any disconnection can be catastrophic during the surgery. Okay. To prevent aspiration, we use throat pack, as you all know. There are different ET tubes available which are to be selected according to the surgery, according to the pathology, and according to the patient need. Okay. Surgical field, yes, the surgeon needs more steel and bloodless field. In most of the surgeries in the ENT, like ear surgery, there are microscopic surgeries, ML-scopic surgery, functional endoscopic sinus surgery. All these need a bloodless field, and that is needed because of having the good surgical vision through the endoscope. So hypotension is induced with the agents that we are going to discuss next. Fire risk is there in case of laser surgeries in laryngeal surgery. So it should be discussed prior with the anesthetist, surgeon, and all the operating team, including the nurses and the staff. Anesthesia, okay, there are different options for the anesthesia. First is monitored anesthesia care, that is local anesthesia with or without sedation. Okay, generally it is opted for the ear surgeries because the patient is conscious, cooperative, and he is allowing us to do the surgery under local anesthesia with mild sedation. But if the patient is too much anxious and not maintaining the proper position, we have to go for the general anesthesia. But these local with sedation should not be opted for the other nose and the deep neck space surgeries, because there can be catastrophe during the surgery. Okay. So general anesthesia with or without endotracheal intubation, it protects the airway, it assures adequate gas exchange, abolishes patient movement, that is important during the micro-ear surgeries, reliably provide amnesia and avoids distractions to the surgeon. Superficial and deep cervical plexus block, epidural cervical, these are also option, but doing the surgery with these local procedure is again a challenge for the anesthesiologist, because after giving the local blocks and cervical epidural, the patient is covered with the drapes, mild sedation is given, and there may be problem with the apnea, and patient may go into the movement. So during the surgery we have to again have to intubate the patient. So it should be ready for the intubation, and these superficial block techniques are not that much recommended for the thyroid surgeries and deep neck surgeries. Okay. Lymph node biopsy and these minor surgeries can be done under regional blocks. Endotracheal intubation, it is again a problem for anesthesiologists, because the airway pathology can be distorted in head neck cancer patients. Any single attempt can deteriorate the airway. So it should be gentle, and minimal attempt should be done for the intubation. If a failed intubation is there, ENT surgeon can help us. Okay, you can help us by intubation with the operating laryngoscope, rigid bronchoscope, and flexible scopy. So it is advisable actually to be with the anesthesiologist during induction, during intubation, because there may be any event that can compromise the airway, and you may be needed to help the anesthesiologist. Okay. In case if the patient is not able to ventilate with the bag and mask also because of the airway and trauma during intubation, so rigid bronchoscopy can be an option to ventilate the patient till the surgical airway is becoming ready. Okay. Maintenance of anesthesia, yes, it is a surgery of complex reflexogenic airway, because any stimulation during the surgery, it is a sympathetic response to the patient, causing hypertension, tachycardia. So for anesthesiologists, ENT surgery itself a challenge to maintain a proper depth of anesthesia, to maintain the hemodynamics throughout the surgery till the extubation and in the post-operative period as well. Okay. So we have to make the stable plane of anesthesia, minimize the bleeding as with the induced hypotension, prevent the post-op nausea, vomiting, and plan for the smooth emergence, rapid recovery, and fast-track discharge. Opioids, yes, opioids should be preferred during ENT surgeries. They suppress the airway reflexes and help to maintain the hemodynamics. Okay. Blood loss in head neck onco surgeries and major endoscopic surgeries, it's a major challenge, and it is very difficult to estimate and convince you surgeon that it is a huge blood loss, because we have to estimate it with the observing the suction bottles and irrigation fluid, and accordingly plan for the transfusion. Can be reduced with the head up position, use of hypertensive agents, tranexamic acid. Okay. Moderate controlled hypotension, as advocated and indicated in the endoscopic surgeries, with the systolic BP of less than 100, and mean BP should be 60 to 70, not less than that. Okay. And there are various drugs, just 2 minutes more. There are various drugs that can be used, including the total intravenous anesthesia. Actually, propofol is the best drug for the ENT surgeries, because it is fast acting, giving good hemodynamics and giving hypotension with risk of post-op nausea, vomiting is also reduced with the propofol. So propofol TY is preferred in the ENT surgeries. Inhalational agents, alpha agonists, beta blockers, they are the preferred drugs for the hypotension. Again, it should be avoided in high-risk patients. Okay, so don't request, don't demand for the hypertension. In case with uncontrolled hypertension, cerebrovascular disease, coronary artery disease, and the chronic liver and kidney diseases. Post-op nausea, vomiting, a high incidence in ENT surgery, and prophylaxis is must. Okay, done with the ondansetron and dexamethasone. Extubation should be a planned strategy, because again it is a high risk procedure leading to higher risk of complications, laryngospasm, airway edema and postoperative airway obstruction. There may be a need for the re-intubation in case these complications occur. Postoperatively also we have to be very vigilant to have the airway complications can occur, because there may be ongoing bleeding, edema is there and residual effects of the anesthetic agents. So we have to be very cautious in the postoperative period as well. So take home message, I want to tell you, this is a shared airway and can be managed as a team very well, both with the ENT and the ENT surgeons and the anesthesiologist. Airway strategy should be planned, and any emergency plan for the second option should be ready prior to the surgery. Intubation is preferred in the deep neck space infections, even though it is a short procedure, okay? And caution with the hypertension in the high risk cases. I just want to mention one case. A few months back we had a case of Ludwig's angina in MGM hospital only, and the patient was elderly male, no comorbidities, so taken for the Ludwig's angina incision and drainage under local with sedation, okay? The anesthetist was very good and vigilant there. They started the surgery with the local anesthesia, and during procedure the patient went into apnea and desaturated. Immediately she had an arrest, and the anesthesiologist intubated the patient, did the CPR and revived at that time. Started the inotropic support and shifted that patient to the ICU. When she came to the ICU, she was with a triple inotropic support with poor BP, not recordable, because it was a post arrest, okay? We planned the drainage procedure of that Ludwig's angina afterwards. 2 times we have to do in day 2, day 5 we have to again did that. And slowly after the stabilization of airway, the patient recovered. We weaned from the vasopressors and ventilator and safely discharged the patient home. So this can be an event with any simple procedure with a deep neck space infection or any ENT surgery. So be cautious and be ready with all the emergency kit with you. Okay. Thank you so much. Thank you.
Any questions? घरी तेच काम करतो ना सर. अरे घरी तेच काम करतो ना सर. Now I request Dr. Ritesh Bhagyavan sir, Secretary OI, to felicitate Dr. Mayuri. Next line, Priya Bhale. Now I invite Priya Bhale madam on the stage to give her talk, cochlear implant from silence to sound. May I have her slide please. Priya Bhale madam is a renowned audiologist and speech and language pathologist working in the Marathwada region. She is postgraduate in audiology and speech language pathology. Has done her post graduation from Mysore University. And since last 25 years she is working in Marathwada, and she was a founder member of Margin NGO working for the empowerment of disabled individuals. She is the winner of first VIMA Award, Lions Award and many more, and felicitated by ex-President Bill Clinton for outstanding work in the field of hearing impairment. She has cochlear implant center done more than 350 cochlear implant cases, and she is a holder of Guinness Book of World Records in fitting maximum number of hearing aids in one day. So I welcome you, ma'am.
Thank you very much, sir, for your kind introduction and giving me an opportunity to talk about cochlear implant. I am going to talk about cochlear implant, a journey from silence to sound. Generally, what we see that hearing impaired individuals are the individuals, they have this disability, but this disability is not seen. Physically, it's not seen. But the issues, because of that, occurring issues are more. And it gives rise to the dual disability. And that dual disability is communication disability and speech and language disability. And that's why hearing impairment becomes very crucial. When we talk about hearing loss, we say that hearing loss is nothing but a person who cannot hear as well as a normal human being. Hearing loss can be mild, moderate, or profound. A person who is called hard of hearing is a person who has hearing loss from mild to severe, and a profound loss is called as a deaf person. Globally, if we see that hearing loss is seen in every region and country, currently more than 1.5 billion people are suffering from hearing loss, and 430 million have disabling hearing loss. That is 5% of total population is suffering from disabling hearing loss, and by 2050 there would be 700 million people who would be disabling hearing loss. That is 1 in 4 people will be suffering from this. If you see that hearing loss affects all age group, that is 1 in 200 infants, 1 in 5 teens, 1 in 5 adults, and 1 in 3 seniors are suffering today from hearing loss. The causes of hearing loss are many. I don't need to talk about causes here, but when we talk about the impact of hearing loss on human being, it is huge, it is enormous. Especially when the hearing loss is sensory neural in nature, then it so happens that the hearing and speech and language is also affected. The child also has problems in his academic achievements. When this hearing loss is seen in the early adulthood, the person has lack of the opportunities for the employment, and that's why his quality of life becomes poor. When this is seen in the adult means the geriatric population, it is seen that because of the hearing loss, dementic changes are seen in them, and they become lonely. They are away from the society, and then they develop the mental health problems. Now, impact of untreated hearing loss is huge. 87% of them are seen to have affected relationship. 86% have impact on their communication with loved ones. 67% have exclusion from the society, and 61% have loss of employment. So, treatment of disabling hearing loss in children and adults is hearing aids and cochlear implants. Now, hearing aid is best for mild to severe loss cases, while cochlear implant is best for moderate to profound hearing loss. Hearing aids is an externally wound device which actually captures the sound and delivers it to the ear. On the contrary, cochlear implants, they bypass outer ear, middle ear, and inner ear, and they give signal directly to the brain. And we will see in short how a hearing aid works.
Including behind the ear, in the canal, and completely in the canal. While the style may vary, all hearing aids have the same basic parts: a microphone, amplifier, speaker, and battery. Here's how they work. First, the microphone picks up sounds from the environment. Then a computer chip with an amplifier converts the sound waves into electrical signals. It analyzes and adjusts the sounds based on your hearing loss and the level of other sounds around you. These amplified signals are then converted back into sound waves and delivered to your ear through the speaker. In this way, hearing aids can improve your hearing and speech comprehension if your hearing loss is caused by damage to the sensory cells in your inner ear. The greater
How the nucleus cochlear implant system works. The nucleus cochlear implant system is designed to mimic the functions of the human ear. Sound travels to your ear and the sound processor, which sits behind the ear. The microphones on the sound processor pick up sounds, and the processor converts them into digital information. This information is transferred through the coil to the implant just under the skin. The implant sends digital sound signals down the electrode into the cochlea. The hearing nerve fibers in the cochlea pick up the signals and send them to the brain, which is translated as the sound you hear. Unlike a hearing aid that simply amplifies sound, cochlear implants send sound directly to the hearing nerve and on to the brain.
So hearing aids and cochlear implants, there is a basic difference between the two. Hearing aids, they pick up sound waves, they make them louder and send them to outer ear, middle ear and inner ear. On the contrary, cochlear implants, they bypass outer ear, middle ear and inner ear and they directly stimulate the hearing nerve fibers. The most important difference between the two is that the hearing aids, they offer limited or no gain in the higher frequency range. On the contrary, cochlear implants have frequency range which is from 188 to 8000 Hz. All our speech frequencies are basically located in this region, and that is why hearing aids give us poor discrimination of speech. So there are limitations of hearing aid. They do not restore normal hearing. Also, they have discomfort and ear mold occlusion. The gain limitation in higher frequencies is very poor. Whatever may be the treatment for hearing loss, one thing we must remember is that hearing is a brain function. Why? Because we are born with 100 billion brain cells, and these brain cells are multiplied by the age of 6 months on the basis of stimulation received from the surrounding atmosphere as well as from our 5 senses. And by the time of 2 to 3 years, this stimulation is increased in many folds and child can relate himself or herself with the surrounding atmosphere. Now, brain needs stimulation in order to develop. The connections that receive constant stimulation are preserved, they are modified and they are saved. And those connections who do not receive any stimulation, they are pruned. And that's why if we want to really make listening brains, we need to start the stimulation at an early age. Listening brain means, what I mean to say is that the auditory cortex and visual cortex, they are situated side by side in the brain. So when the stimulation comes from the eyes and the stimulation comes from the ear, these cortices, they develop. But if you do not give stimulation from the ear, then the visual cortex takes over the auditory cortex. So much so that it occupies completely the area of auditory cortex and the listening brain becomes a visual brain. So when it becomes a visual brain, the child cannot learn speech and language, because to learn speech and language, one has to hear. And if the auditory cortex is completely occupied by the visual cortex, it is very difficult for the child to hear. So earlier it is for the brain to develop, the earlier treatment is needed. The earlier you do the treatment, we can give rise to the listening brains. That is why Universal Newborn Hearing Screening Program was launched, because they said that earlier you diagnose and earlier you treat, it will be better for the future of the child. So the program actually said that at 1 month of age, the child should be screened. At 3 months of age, if the child fails in the screening, the total diagnostics should be done. And at the 6 months of age, complete rehabilitation has to be done. Now that plan has modified from 136 to 123, keeping in mind the neurodevelopmental emergency. Hearing loss in babies is now called as neurodevelopmental emergency, because there is critical time for an optimum auditory neural connection to happen no later than 6 months. And if we want better results, we should start early. So these hearing aids or cochlear implants, they are nothing but brain access tools. And these brain access tools actually make us hear the sound. Hearing is making sound available to the brain. Later, the brain listens to this sound, he pays attention to it, he modifies it, and he saves it in the auditory cortex. Once the sound is saved in the auditory cortex, then only that sound can be used for verbal communication. So, these brain access tools should be given to the child at an early age. So, if a child is born with a hearing loss, then the most important thing we should keep in mind is the timing, because timing is most critical to optimize the outcomes. There is this study which was done by Rogers and Moody, and they said that infant hearing loss is a neurodevelopmental emergency. And if we want our children to have the journey from silence to sound, we have to keep in mind the time factor, because if we don't keep that factor in mind, our children will not travel this journey and they will not be successful. Neither will they be successful, nor will the professionals be successful. That's why we should consider infant hearing loss as a neurodevelopmental emergency. Thank you. Thank you for giving me this opportunity. Thank you very much.
Thank you, ma'am, for a nice informative talk. Any questions?
My question is a little bit theoretical, Priya. As you have worked with 350 cochlear implants, is there any device which can detect subsonic or ultrasonic frequencies, or are there any these frequencies modulators which can hear the subsonic sound like elephants do, or ultrasonic sound like bats or other birds? Is there any?
I'm afraid that there is nothing of this kind which has been evaluated by humans. It is only seen in the nature that bats have suprasonic frequencies they can hear, and the yes, we have this technology in hearing aids, where when people do not have frequency, means hearing in higher frequencies, we can actually bring those frequencies in the lower frequency version, and we can make it available in the lower frequency range for hearing. No, in cochlear implant, any which ways in cochlear implant we don't need this, because cochlear implant has a entire frequency range from 188 to 8000 Hz, what is human needs to hear.
Thank you, ma'am. Now I call upon Dr. Sauji sir to
One
illustrate.
patient has asked me, is there any real-time translators available in hearing aids?
Real time?
Translators.
Yeah, hearing aids, yes. There is one hearing aid which was launched by Starkey last year, and that hearing aid got global award, and that hearing aid can translate 52 languages. So if you have that, that is called artificial intelligence hearing aid. If you, if you open that system and if you start that, it will start translating the
Real-time
languages.
translation.
Yes, real.
How much is the cost?
3.5 lakhs per hearing aid.
Okay, thank you.
Thank you, ma'am. Now I call upon Dr. Sauji sir to felicitate Bhale ma'am. Next speaker is Dr. Nilesh Lomte. He will enlighten us on medical management of thyroid disorders. He is an endocrinologist practicing in Aurangabad.
First of all,
I would like to thank for kind introduction and giving me opportunity to talk here. I will briefly go through these thyroid disorders, and I will finish in 10 minutes. So let's start with my today's agenda. Today's agenda is first I will show one case, then hypothyroid, hyperthyroid, and thyroid nodule. Few slide on each subtopic. So start with my case. She is a young lady presented with typical features of hypothyroidism, that is generalized weakness, neck swelling, menorrhagia, and her biochemical profile, thyroid function clearly showed a raised TSH, and that is the typical case of hypothyroid. So let's start with hypothyroid. So prevalence of hypothyroid in Indian scenario is near about 10%, and it is higher as compared to Western literature. Around 42 million people are affected in India by hypothyroidism. And these are the different types of hypothyroidism. Primary hypothyroidism is the most common type of hypothyroidism, and followed by secondary and tertiary. In secondary hypothyroidism, most common causes are cellular masses, cellular pituitary surgeries, and related things. So thyroid mainly affect body through the affecting the basal metabolic rate, and it affects the each and every system of body. It act on the GI system, bone system, reproductive system, brain system, and metabolic system. So anything alteration in the thyroid can lead to multiple system affection, so can lead to multi-system presentation. This is the natural history of hypothyroidism. Initially in subclinical hypothyroidism, just rise in TSH we see, and there is a normal T3 and T4. Once it becomes overt hypothyroid, then TSH rises sharply along with decrease in the T3 and T4 levels. So what are the recommendations for the treatment of hypothyroidism? As per ATA 2014 guideline, we can start as a full replacement as a 1.6 microgram per kg if a patient is having this frank hypothyroidism, or we can start as a partial replacement with gradual increment, and we can reassess after 4 to 6 weeks to look for the normalization of thyroid function test. During the starting of dose, we need to see these different factors that affect the dose of hypothyroidism. These are the patient weight, baseline thyroid function, pregnancy status. In pregnancy, we need to give 30% higher dose as compared to normal population. Higher the TSH level, higher the dose is required. Etiology of hypothyroidism: in total thyroidectomy patient, we need higher dose as compared to primary hypothyroid patients. Then age, we have to undertreat as advancing age to prevent the cardiac risk. And if patient have underlying cardiac disease, we need to give lower doses to prevent the cardiac arrhythmias and tachycardias. So these are the different factors that can affect the thyroid supplement dosages. Coming back to my case, most of times our patient didn't give proper history, and we have to ask repeatedly. After repeated asking different questions, patient gave history of she was started on anti-thyroid medication 3 months back on the carbimazole 10 mg/d, and she lost to follow up and then presented after 3 months. So and her investigations showed thyroid scan showed Graves' disease 3 months back, and in between she was lost to follow up. So clearly she was a case of Graves' disease, hyperthyroid, on treatment with anti-thyroid drug with drug-induced hypothyroidism. So coming to next part of my presentation, hyperthyroidism. These are the different types of hyperthyroidism. Still most common cause is Graves' disease, and different causes are like subclinical thyrotoxicosis and thyroiditis. These are the second and third most common causes of hyperthyroidism. So these are the different presentations of hyperthyroidism. We all know weight loss, tremor, palpitation, excessive sweating. These are the common presentation of hyperthyroidism. Sometimes Graves' disease can have clinically active Graves' arboretopathy. That is the involvement of eyes, swollen eyes with redness and pain in the eyes. So it is called as clinically active eye disease. In that scenario, we have to give pulse steroid therapy to tackle this kind of scenarios. Then coming to treatment part of hyperthyroidism, treatment of choice, we have 3 options. We can select one of them. So in pregnancy, we select, most of times we advise antithyroid drugs. Again, in patients who have active Graves' arboretopathy, in that scenario also we select antithyroid drugs. But if patient have comorbidities, or patient is having cardiac disease, in that scenario we go for the radioactive therapy. But if patient is having large goiters, compressive symptoms, malignancy, or patient need other surgeries like parathyroid or adenoma surgery, in that scenario we go for the surgical management of hyperthyroidism. Coming back to same patient, then clinically she had a goiter and it was confirmed on the EVG as a diffuse goiter. So coming to goiter part, around 4 to 6% patients of thyroid goiter or nodule can land in the stage of cancer, and if they have previous history of radiation, in that scenario this prevalence is high, that is up to 20 to 50% of percentage. So in investigation of goiter, investigation of choice is ultrasonography. There are several features which suggest the underlying malignancy. These are the microcalcification, irregular margins, hypoechogenicity, taller than wider, and increased vascularity. If two or more than two symptoms, these features are present, then we can suspect the malignancy. There are clear-cut indication for FNAC as per advice by ATA 2014 guideline. Diffuse goiter is not an indication. Many a times in practice we come across patients with diffuse goiter already coming with FNAC. So hypoechoic nodule more than 1 centimeter, hyperechoic nodule more than 1.5 centimeter, solid cystic or spongiform nodule more than 2 centimeter. In that scenario we can advise FNAC, or otherwise no need of FNAC for diffuse goiter or sub-centimeter nodule. Or purely clear cystic nodule also there is no need of FNAC. We can manage medically or surgically. And FNAC should be reported in the Bethesda category wise, and Cat 2 is a benign lesion. They have chance of malignancy up to 3%. In Cat 6 risk of malignancy is around 99%. But there is always a problem in managing a patient with Cat 3 and Cat 4 because of there is a indeterminate result on Cat 3 or follicular neoplasm in Cat 4. In that scenario we can take help of this genetic marker. If it comes positive, we can go ahead with total thyroidectomy and we can confirm it as a malignancy. If it comes negative, we can prevent the unnecessary total thyroidectomy or hemithyroidectomy. So these are the emerging modalities. We can do molecular testing. These are the different 6 genes like that. These are the BRAF, NRAS, HRAS, KRAS, RET, PET and PAX8, PPRA gamma. So coming back to same patient, I reduced the dose of antithyroid medication. After 1 month thyroid function test came to normal, and after 6 months goiter regressed even without any surgery or any other modality of treatment. So to conclude today's session, detailed history taking and investigations are very important in managing the thyroid disorders. Before starting T4 supplement, that is thyroxine supplement, factor affecting dose should be considered, and we have to modify dose as per requirement. If Graves' disease patient started on anti-thyroid medication, should be continued for at least 18 months for remission. Around 30 to 40% of Graves' disease can land in the remission after treating with thyroid medication, and they can have off treatment euthyroid status afterward. Diffuse goiter majority of times regress by medical management if it is associated with hypothyroid or hyperthyroid. If it is euthyroid, then we need to evaluate detail, and FNAC should be avoided in diffuse goiter and sub-centimetric nodules. Thank you for patience listening and giving attention, and I would like to thanks for giving me opportunity to talk here. Thank you.
Thank you, Lomte.
Thank you,
That was
Nilesh.
wonderful.
Nilesh, I just want to ask you one question. Is there any formula to calculate the dose of thyroxine tablet which we prescribe routinely for a hypothyroid patient? Means there is some formula like TSH level is like that, and you prescribe the...
Basically in overt hypothyroidism, overt means very high TSH with low T3 and T4. In that scenario, we start with 1.5 to 1.6 microgram per kg, but TSH is on lower side, we have to reduce the dosages. If a patient is elderly or patient have comorbidities like cardiac disease, we have to give less dosages. If patient is obese or patient have associated pregnancy, in that scenario, there is no
formula like
no,
TSH
yes,
is 6.
It's like diabetes only. There is no formula for insulin. There is no formula for thyroxine supplement also. Yes, sir.
Thank you.
How do you treat a patient T3, T4, TSH normal and a hypothyroid?
I request Savji sir to felicitate.
It's my pleasure
Because
to
of
take
time
question.
constraint.
Yes,
Yeah,
one minute.
yeah.
I will finish in 1 minute. Okay, sir. It's pleasure to
T3,
take question.
T4 normal, TSH is 0. How do you treat these patients?
This is a subclinical hyperthyroidism.
Exactly.
First, we do a thyroid scan, and as per etiology, we treat. If it comes as a thyroiditis, we just give beta blockers. If it comes as a subclinical Graves or just mild Graves, we have to treat with antithyroid drug. Yeah, right. Thank you, sir.
Because of time constraint, we have to rush through. Next speaker is Dr. Anup. Anup Toshnewal is an oncophysician, a dynamic oncophysician, a medical oncologist. He is extensively trained in science and art of medical management in cancer patients. I request Anup to enlighten us on.
Basically, sir, I am Dr. Anup Toshnewal. I am a medical oncologist. I did my DM from Tata Memorial Hospital, Mumbai, and I know I am keeping away from the lunch, so I will be very brief and short. My talk is divided into two parts. One is what is medical oncology and what is a multidisciplinary team, and what is the scope of medical oncology and whether it is limited to administration of chemotherapy. Second part would be the role of medical oncology in different perspective. Now, already speakers before me have covered lot of parts, so I am very thankful. So I will just rush to the first part. Basically, we have three modalities mainly: surgery, radiotherapy, and systemic therapy. But surgery and radiotherapy both are forms of local treatment. They can only cure locally. They do not cure the systemic micromets. The small tumor cells which are let into lymph or blood, they cannot be taken care by any kind of surgery or radiotherapy. Also, systemic therapy takes care of local as well as the distant tumors. But they are not mutually exclusive. As we all know that there is always a combination of these therapies. Now, medical oncology, basically what we do is we coordinate, we basically use systemic therapy, that is chemotherapy, targeted therapy, immunotherapy, and other functions of medical oncology in a tertiary care center. And does systemic therapy means only chemotherapy? No, we have other forms of treatment. Chemotherapy given what you generally know is maximum tolerated dosing therapy, metronomic dosing of method, targeted therapy, immunotherapy, hormonal therapy, and supportive care. Now, coming to the main part, part B, that is role of medical oncology in multidisciplinary setting. So first I'll get to the in perioperative setting. That is more interesting for the ENT colleagues because that is day to day what they have to deal with, and palliative setting. So my focus here will be in the neoadjuvant setting, preoperative, because in India, as we all know that due to tobacco chewing and tobacco abuse, we'll get lot of advanced cases, and it is difficult for ENT surgeon to operate on those cases. And second is there is lot of economic constraint, and lot of patient cannot afford the standard dose of standard treatment which is recommended by oncology. So my focus will be on these two subjects only. Now, I'll just describe through this case because the theoretical talks becomes a little boring, and that's why I have come with these cases. These are real life cases. 50-year male, no comorbidity, no drug allergy, reformed tobacco chewer, locally advanced left-sided CA buccal mucosa with skin breach, edema up to zygoma, biopsy shows squamous cell carcinoma. And you can see very well here that the constipation and grade 2 mucositis, no admission for febrile neutropenia or grade 3-4 events. And this is the post-chemo picture. You can see the lesion has shrinked, the edema has gone, and the patient actually is hollowed. This is post-chemo induced alopecia. And this is the another photo. Here you can see it has healed very properly. And this was referred to by Dr. Shailesh Agrawal. This is the post-operative photo of the patient. And why I wanted to highlight this case is if it was not referred to a medical onco, or it was not discussed in a multidisciplinary team, patient would have not come up for surgery. Only palliative chemotherapy would have been offered to this patient, and OS, overall survival of this patient, would be less than a year. And then there is morbidity of tumor. You have urocutaneous fistula, severe pain, infection, maggots. If it is referred, discussed whether this can be taken up for surgery, later chemotherapy, then patient underwent a curative surgery, had a superior aesthetic outcome, expected overall survival around roughly 3 to 5 years with potential to cure the disease, and morbidity of tumor was avoided. Now, this is a study I want to quote from my home institute. Generally, the referral pattern for neoadjuvant chemotherapy is more than 90% of time to achieve the resectability and organ preservation. There is no difference, much difference in overall survival. There is only 3% benefit of giving chemotherapy before surgery, and that too only borderline cases. Operable cases should be directly taken up for surgery, and at Dr. Borgakar had said that N0 trial, we have to even electively do N0 for neck dissection in N0 cases. Now, coming to what are the indications for referring for an NACT or where NACT should be done. It is extensive skin infiltration, peritumoral edema reaching up to or above zygoma, peritumoral edema reaching up to hyoid, that is below, up to hyoid, infratemporal fossa, borderline resectability when the ENT surgeon is not comfortable that he might achieve a R0 resection or not, extensive involvement with the floor of the mouth, and for sometimes medullary preservation. Now, there is no role of chemotherapy in adjuvant setting. It is only indicated, this is perioperative, so I am coming post surgery now. So it should be only given in concurrent with radiation. The indication were showed by Dr. Amalu Bade. There is no role of adjuvant chemotherapy. Targeted therapy is only given in this concurrent setting if a patient is not eligible for docetaxel or cisplatin. And role of immunotherapy in neoadjuvant, that is preoperative and postoperative setting, is evolving. Now, this is just to show, this is the McKinsey analysis, this is the holy grail of medical oncology. Generally, we refer to these papers to decide regarding the long term, whether we want to give chemo or not. This is almost 19,805 patients, and we can see that the benefit of giving concurrent chemotherapy, the overall survival benefit is 6.5 years, 6.5% at 5 years, and it dips to 3.6 at 10 years. And effect of adjuvant therapy, like you have done a surgery, referred for radiation, post radiation also some people give chemotherapy as adjuvant, but actually it harms the patient. It is minus 0.3% at 5 years. So the survival of patient is actually inferior if you give only adjuvant chemotherapy. So some people have habit of extrapolating data of breast cancer, stomach cancer or colon cancer. Ki breast cancer we do surgery, you chemotherapy, or colonic cancer you do a surgery and then refer for adjuvant chemotherapy. In head and neck cancers, it is not the same. Actually the survival is inferior if you give adjuvant chemotherapy. Now, coming to another interesting case, this is also a neoadjuvant case, 32-year male, right-sided buccal squamous cell carcinoma, extensive skin involvement, otherwise fit, took Ayurvedic treatment 4 to 5 months, progressed on that Ayurvedic treatment, and he told, "Mar jaunga par chemo nahi lunga." His father had died due to complication of chemotherapy. Chemo was given by a non-qualified person in wrong doses, so that poor guy died due to complications of chemotherapy. And then after extensive discussion, he did not want any kind of IV chemotherapy. So we tried to give him oral chemotherapy only. So oral chemotherapy is oral metronomic chemotherapy. Cost per month is at roughly 5 to 6,000. It is available in MJPJY also. And side effects are minimum. And you can see this is the baseline tumor. Patient had taken photo himself. And this is after 1 month of oral chemotherapy drugs only. And it has beautifully shrink, and here the scarring has formed. Now then, after 3 months of oral adjuvant, neoadjuvant chemotherapy, patient underwent surgery. This is a flip photo because it was taken in a mirror, and then completed adjuvant CT-RT, and now patient is doing well. Now this is what we have seen in neoadjuvant setting. Now coming to role of medical oncology in metastatic setting or palliative setting when already the tumor has spread and it is beyond any curative form. So we have 3 modalities: chemotherapy, which is given either as oral metronomic chemotherapy or which is given in maximum tolerable doses. Targeted therapy, here we give specific drugs which hit specific target. Although in head and neck there are only 2 targets as of now, 2 drugs available, that is for EGFR targeting, nimotuzumab and cetuximab. And immunotherapy, here there are 2 types of immunotherapy. One is PD-L1 and PD-L1 ligand inhibitors, that is programmed Det1 receptor inhibitors, and CTLA4 inhibitors. Now I just give one case in this palliative setting. 34-year male, poor farmer, reformed tobacco tumor, very aggressive locally advanced tumor, not affording for any kind of treatment. Accessibility was also issue because patient was from far away and rural area. He was started an oral metronomic chemotherapy, and this is the baseline tumor. You can see this is such a horrible tumor. And then we have started just OMCT. This is after 2 months. Patient did well. there was decrease in pain with wound healing, but eventually patient succumbed after 8 to 9 months of treatment. So here we can decrease the financial toxicity to the patient, and it is very much doable. Patient has to just take tablets at home. We have to just monitor once in a month, and this is very much doable in resource constrained settings. And I also wanted to highlight some excellent work being done in Tata Memorial Hospital. This is my teacher. This is a publication from Lancet Global Health, that low-cost metronomic therapy versus intravenous cisplatin in patient with recurrent or metastatic or inoperable head and neck cancer. This is an open-label parallel group non-inferiority randomized phase 3 trial, and here they have shown that it is non-inferior to the standard of care, that is IV chemotherapy. So IV chemotherapy as well as oral chemotherapy, they do equally well. And this is another exciting area. A lot of patients are not eligible for concurrent chemotherapy due to old age, renal failure or hearing issues. Cisplatin cannot be given. There's new drug which has come. This is very less people understand giving docetaxel as a radiosensitizer in adjuvant setting for this. Now, what I could not cover because due to time constraint is due to targeted therapy, rare tumors like nasopharyngeal lymphomas, osteogenic sarcoma of jaw, esthesioneuroblastoma, nut midline carcinoma, and thyroid malignancies. Other sites like naso-oro and hypopharynx, and role of NGS. Now, just I wanted to present this slide. This is what is now presently status of systemic therapy in head and neck squamous cell carcinoma. Chemotherapy in neoadjuvant setting is very well established. It is the main aim of chemotherapy here is to just make the tumor resectable rather than providing any PFS or OS benefit. Then in adjuvant setting post surgery, when surgically not possible but patient is referred for definitive radiotherapy there, and in palliative settings. Oral metronomic chemotherapy, neoadjuvant, it is evolving, and it unethically, because patient always in oncology comes for second or third opinion. Thank you.
Thank you, Anup. Excellent talk. Any question? We can allow one question. Thank you, Anup.
Yes. Thank you, sir.
Now I call upon Dr. Sachin Nagre to felicitate Dr. Anup. Next. Next speaker is my close friend, Dr. Jeevan Rajput. He himself doesn't need any introduction. He is a dynamic entrepreneur right now. He is coming up with a big setup in Aurangabad, JJ Plus Hospital and Neuron International. He is a consultant neurosurgeon.
Good morning all. You should wake up from the sleep and we should wait for only 10 minutes. Obviously I know it's very late, but nothing more than know. Pituitary itself is a philosophy rather than anatomy and physiology. If you know pituitary gland tumors, they are controlling whole body. And all previous talks are about cancers. Something happens to patient. It is very easy for us to explain that patient was having cancer, and now we should be sad, but in some part we should be happy that he ended up his life just to get out of that cancer. But in case of pituitary, we can't explain that it is a physiological tumor rather than most of the time, and being a benign tumor, we should be very cautious and very meticulous while dissecting tumors. Slight amount of traction, slight amount of post-operative diuretic phase, slight amount of pituitary stalk effect, it will land up in a disaster. Sometimes those people are newer curve. There might be a frank CS of leakage that may lead to hypotension, cranial hypotension, and that could be disaster. So, my friend, it is very, very must to know that dissection of pituitary in a small area with small delicacy is very important. And to proceed with delegation, we should have a proper window. And window is being created by UENT surgeons as a team. My colleague and my friend Ritesh Bhagyavan and his team is doing fantastic job for me, and they are giving me very fantastic room and a very fantastic window for an operation for dissection of the pituitary tumor, and we are proud to say that we are maximum operating pituitary surgeons in the Marathwada region and central Maharashtra region. And regarding complication, for the first time, if patient is being operated, I think only one patient was put on ventilator and he recovered after that. Otherwise, more than 130 cases, we are having 100. Success rate is 100% in first setting. In case of a recurrence, there is a death rate. Obviously, 2 patients that died with 30 cases of recurrent surgery, and that's why it is very important. If first we can explain in second time, but in first time we can't explain the death and complications. So should be very cautious in that way. So proceeding with the introduction, we will not waste time because all we know it is very endocrine tumor, 15% of the brain tumor, all this thing. And regarding surgical intervention, I can operate without endoscope through my microscope, sublabial or transnasal. But I am very much familiar and now found with the new innovative technique that is called as 4-hand handle technique with high definition endoscope with the help of my ENT friends. So, in overall pituitary macroadenoma required surgery when it is causing physiological effects or mass effect. So we can say if it is more than 1 centimeter, it is causing mass effect and it is causing bitemporal hemianopia, and that time we are indicating. So indications, it is very long list. You might be knowing that pituitary tumor and its classification and surgery tics, it will take one complete CME. So in short, we are covering it in a very fast way. So we will not waste. It is a preoperative scan is very important, MRI and CT scan. We should look the coronal as sagittal section. So to check the patency of the sphenoidal sinus and location of the tumor size in respect to the surrounding structures. Preoperative evaluation is very important. We can go, those person who are thinking that we will plan or we will start some endoscopy surgery here as a ENT surgeon or as a other surgical intervention, they should be familiar with the basic anatomy, and that is very important. Next thing, regarding surgical technique, it should be done in general anesthesia. We should have a 20-degree extension with head turns to the right side for the right side operating surgeon, and we should have a proper endoscope with a proper degrees. So before going for the tricks and difficulties, we'll summarize small steps in 2 to 3 minutes. So while proceeding, first we'll get the first view of endoscopic is middle terminate, inferior terminate, septum, and once we proceed scope further, we'll get incision tube, nasopharynx, sphenoid recess, and once we are getting sphenoid recess, we should lateralize the medial terminate so that with the help of cotton patty, and once we are lateralizing it, we'll get proper sphenoid ostium. Once we are reaching to the ostium and we are getting proper recesses, so ENT friends are getting, we're doing their job by doing nasoseptal flap, and then partial recession of middle terminate can be done on either side for if there is a hypertrophy or for getting easier entry. And once we reach inside, we'll get V-shaped shoulder sphenoid osteotomy, and where sphenoid ostium is enlarged inferiorly and medially, and later on we can break the sphenoid rostrum with the bony punch, and posteriorly we can break the middle posterior septotomy to be done by backbiters. Now sphenoidectomy, it should be done very delicately, and we should know all the borders, right? All the borders mean superior, inferior, and lateral at the other side, because all surrounding we are having important structure to know about it. So we are going to expose the sella. After exposing, we should get this endoscopic view wherein we can see this is a fetal face-like structure where you can find the center there is a sella. So at 12 o'clock there is a tuberculum sella. There is a clavum indentation. On either side 3 o'clock and 9 o'clock there is a carotid protuberance. You can say at 10 o'clock and 2 o'clock position there is a optic protuberance. And once we get all this clearance, so we can say that now it is adequate exposure is there, so we can proceed for the drilling. Before that, sometime we may find some different type of sphenoid septums. Sometime midline sphenoid septum to the central part of the sella or a paramedian. So we should be aware about the anatomy in preoperative stage. We can plan that CT scan, thin slice CT scan, and we can go accordingly. Now once we are planning for the drilling, so we should point out where we are starting. So we should start at the center, and while doing the drilling the sella, we should open it up, and once the small hole is made up, we can dissect with the dissector, dura dissector, curve dissector, so that to avoid the injuries. So dissection level should be anteriorly, we can find anterior intercavernous sinus, posteriorly posterior intercavernous sinus. On either side there are right and left cavernous sinus limitations. So exposure should be very, very fine and very meticulous. So there are different type of methods for dura opening. This is the standard old used to do. Nowadays there are additions that what we are doing is cruciate type, sometimes U shape. So there are different type of opening we can plan according to the location and extension of this suprasphenoid and lateral extension. So once we are entering to the tumor, we can find there are different consistency. Sometimes it is soft suckable that can be sucked by the suctions. Sometimes it's a firm which will be dissected with the ring, and that will be hold with the forceps. Never ever retract the tumor. Never ever pull, never ever push. So pulling and pushing is not indicated. We should have a side to side movement with the suction, and we should start our dissection from the posterior part initially. So we should get the tumor free with the ring curator, and we should get the tumor out with the suction. So there should be the main crunch lies here. If we are not aware what is normal and what is abnormal, and how it is only and only possible with your learning curve, only after learning curve. So in initial part, I would recommend you or my friends, if we are we are having an entry into the endoscopic nasal surgery for pituitary, we should be assisted with the senior one who is already well versed in that. Because normal pituitary is pink here and tumor tissue is just slightly brownish here. So that will be posteriorly pushed gradually, and suction should be moved in a lateral brushwise manner, and it should be sucked properly. So removal of the tumor should be done posteriorly and then on either side, and then go anteriorly. We should check all the angles, so we should not miss out any remnants or any residuals. And it is very important to decompress bilaterally, to decompress optic nerve compression, so that visual will be improved. Because my patient has come to us because of visual impairment, and we should improve that vision post-operatively. As we did pre-operative testing, post-op also we need to do perimeter. So after complete removal of the tumor, you can see the bulging of the arachnoid bulge here. So this is the diagrammatic representation for that. And once we are okay with the bulge, we can check with the valsalva manual. We can ask our anesthesiologist to give a valsalva manual, and if we should recheck that there is no leakage. And I know once after your practice, hardly any time any 1 or 2 cases you will get leakage. Though there is leakage or not, but we should, if we plan proper cellular reconstruction, and if you plan proper reconstruction, there is no need for any lumbar puncture or lumbar drain. In hardly only one case we put lumbar drain in post-operative. We are so confident enough now that we don't need any lumbar drain in post-operative cases. That is the key role, because we are avoiding arachnoid rupture and CSF leakage. And on the contrary, because of adult flap and that bony flap reconstruction, we are making sure that there should not be leakage. Though patient may be in Yojana or not, sometimes you are using glue, that is costly one, but we don't compromise the quality of the patients. So endoscopic view after cellular package, you can see sometimes you are pitting fat can be taken from abdominal side or this one. So it's only 1 minute now. So medalization of the medial tumor after completion of the tumor here, this one. This is pre-op, this is post-op, endoscopic, and post-op one. So what is cheap? Just to summarize it now. So while introducing the scope, one must take the advantage of elasticity of the alar cartilage, and therefore retract the alar nose cranially, and deforming the right nostril and suctionation scope scope at 11 o'clock position. So instruments should be slowly introduced, taking advantage of the rigidity of the floor. And they should be glided gently along the nasal septum below the endoscope through the nasal part. So scope should be introduced slowly, like passing through a tube without touching the wall, and to avoid the swelling lens. So insertion of the instrument by endoscopic guided visualization and keeping the suction at low setting is very important. It will avoid injury to the mucosa, and bleeding for the mucosa should be controlled by infiltration or coagulation. In and out movement inside the nasal cavity should be avoided. So quick movement in proximity should be avoided. Distance between the tip of the instrument and the scope is around 1 centimeter, and it should be simultaneously, they should not touch each other. Okay. So we should prevent lens fogging with warm saline irrigation and avoid mucosal coagulation in upper part to maintain olfaction. Splenectomy should be adequately widened to remove the coughing effect. That is done by ENT surgeons. And drilling first to close target and then surrounding. We should repeat the warm saline with the 40 degrees Celsius. Do not coagulate near the sella. Superiorly, arachnoid may be bulged around the diaphragm cell in front of the thinned out, and we should be very much sure about the CSF leakage. If there is a leakage, we can pack with the glue and this one. So now post-operative care is ICU management. We don't need to discuss here about. Take home message is very short. Just it is having learning care curve, so you should be very cautious in initial time. If you are having any difficulty, you can always come to our new setup also. And attending workshop and doing more practice will reduce your curve. And I recommend all you should go with the 4-iron technique to go with the easy process and smooth process. Thank you very much, and thank you for being here till the last moment. I know it's very late, but thank you.
Thank you, Dr. Jeevan sir, for an excellent talk. Now I call upon Dr. Sauji sir to felicitate Dr. Jeevan Rajput. Thanks to the patience of the chairpersons, they have all enjoyed the interdisciplinary talks. Now I request Dr. Sambhaji to felicitate our chairpersons, Dr. Gaurav Patel. Dr. Jinturkar sir to felicitate Dr. Gobre sir. Dr. Bisegaukar sir to felicitate Dr. Parag.
Now the last but the most interesting session is hearing restoration in the discharging ear. It's a panel which will be moderated by Dr. Maruti Kalyankar sir. So I invite Dr. Maruti sir to be on the stage, and I invite the esteemed panelist of this panel. So I invite Dr. Minesh Juvekar sir to be as a panelist on the stage. Afterwards. I invite Dr. Ravindra Ghumre sir, Dr. Sandeep Agrawal sir, Dr. Rajiv Pastapur sir, Dr. Gajanan Kashid sir to be as a panelist. I invite Dr. Shaligram Tonde sir to be to chair the session. He is not there. Dr. Priya Shende ma'am, chairperson, and Dr. Rameshwar Pawar sir. Please be on the stage.
Good afternoon, everybody. Respected chairmen and dear friends. This panel is on discharging ear, surgery for the hearing restoration. Actually, this is a very big topic and it is not possible to cover it in 45 minutes. Each situation needs to be a separate panel discussion. I request all panelists to be have a brief answer and give the tips to the juniors. I welcome all panelists. Dr. Meghnath sir has left just now. Dr. Manish Juvekar from Mumbai, Anand Gore from Latur, Dr. Praveen Gumre, Ravindra Gumre from Bid, Raju Pastapur from Gulbarga, Karnataka, Sandeep Agrawal from Jalna, and Dr. Gajanan Kashid from Ahmednagar. Well, I am extending in this topic, that is the secretory otitis media, otosclerosis, sensitive hearing loss and cochlear implant. Well, Dr. Gajanan, the patient present with such type of different endoscopic finding in your OPD, how you will evaluate the patient?
Firstly,
clinically.
Clinical examination, audiometry, then firstly clinical examination, audiometry, then if required CT scan, and if ear is discharging after giving antibiotic, then culture and sensitivity to make ear dry.
Yeah, Vinesh?
Yes, similar to it, because some of them are destructive bony lesions, some of them are a little more tympanosclerotic and a little mucosal type of lesions. So one is, of course, you have to know if the patient is in the active stage or the quiescent stage, and CT scan, according to me, is very, very important.
But for unsafe otitis media patient?
No, for
Yeah,
I do a CT scan routinely for all perforations. Okay, depending on the history. If the patient has a very short history of maybe 6 months hearing loss in inactive stage and a clean, good central perforation, then maybe yes, CT scan can be avoided. But otherwise, a long-standing history, like all these pictures look like chronic disease. So in these cases, I think CT scan, along with giving a good antibiotic, I also give an oral steroid for some of those lesions down, where you have some granulation amount of tissue which is seen. Yes.
Here there is a destruction of attic, and even there is exposure of
definitely there is exposure of the facial, but reddish granulation is an indicator of some amount of active disease. Even a suction microscopy here would help to try to clear any debris which is there. We can send for culture antibiotic sensitivity, but I think that's sometimes more academic. Most of the time doesn't come anything great. So first and foremost, you have to work all these patients up from the surgical point of view, apart from the audiometry. That's of course a must.
Can I add something?
Yeah.
If there is huge more granulations in attic region and not responding to any antibiotics, Then I sometimes add some rifampicin powder there, and it gives good results.
Rifampicin powder?
Rifampicin powder. In powder inside the capsule, rifampicin.
What is the purpose of giving that?
Just to reduce the granulations before surgery.
Do you have any experience of using rifampicin, Anish? Anand?
No, I've never used it.
So, OPD evaluation is by clinical and audiological, as well as you will advise the CT scan for the patient. Now, well, there are approaches, that is the transcanal, endaural and endometrial approaches. And microscopic ear surgery and endoscopic ear surgery we used to do for the routine as a surgical approach. Then in this topic we are going to discuss about the tympanoplasty, inlay, interlay or cartilage tympanoplasty, and tympanomastoid surgery, that is canal wall up and canal wall down. Well, tympanoplasty, that is a surgical reconstruction of the tympano-ossicular system that includes canalplasty, myringoplasty and ossiculoplasty. The aim of doing tympanoplasty is eradication of disease, restoration of the tympanic membrane aeration and reconstruction of the sound conduction mechanism for the hearing. So this is the routine case we day-to-day encounter, it's tympanoplasty. The people have preference about the inlay tympanoplasty or interlay tympanoplasty. Some do posterior inlay, anteriorly interlay technique. What about your views of each panelist? I would ask, what are their views of doing tympanoplasty?
For type 1 tympanoplasty, initially we were doing inlay technique. Over a period of time, we have shifted to interlay. That is a better way of treating the type 1 tympanoplasty. Type 2, type 3, depending on the situation, either add a cartilage to that. Basically, this is my idea of treating.
I prefer mainly interlay technique because it gives good support medially and graft placement is quite good. Interlay technique.
Okay. Nish?
Well, I decide the technique depending on the size of the perforation. Now, when we are talking about interlay technique, we are talking about elevating the outer epithelium and keeping the graft between the inner mucosal layer and below the epithelial layer. So my basic principle is that you have to have a good amount of remnant tympanic membrane around for the interlay to basically have some support there. So if you have a subtotal perforation, I don't think interlay is a very good idea. So the type of perforation is very important. Yes, it has its advantages, but then if it's a small or a moderate perforation, like in the first picture where there is some amount of remnant tympanic membrane, an interlay would be a good idea. Otherwise, I do a proper cuff, a 360 or 270 degree cuff technique in which we elevate it right up to the mucosal layer and then put in a graft throughout the canal. That's what we do, if it's a large perforation. And I always keep the annulus intact. So I elevate the fibrous annulus, I put in the graft, and then I reposit the fibrous annulus like it was. And according to me, I just don't agree with the concept of total annular excision.
What about TAE? That's all.
I don't know why people are trying to emphasize on the TAE, and there is a big TAE lobby, I know, and things like this. But I can emphasize the principle why TAE is not the right idea. I will tell you, if I have 1 minute time. Since we're getting to that. Now, what is a tympanic membrane? A tympanic membrane is basically a drum which has a tension on all the sides, just like a drum of a tabla or drum of anything. So it's a drum. So you have to have the principles in mind that the more tension on all the sides and the more well stretched the drum is, it's easily going to vibrate. So when that comes into play, your cartilage is of course going to have some amount of dampening effect. If you have a fibrous annulus which is not placed around the border, it's fine. But if you have an annulus which is there, which is helping us to stretch that drum and helping us to stretch the graft, keep it in place, that's going to be a more effective thing rather than removing it totally. That's my idea, and I don't think removing the annulus has too much of value. But of course, coming back to a question, yes. So interlay only when there is a moderate or a small perforation. Otherwise, I go for a complete cuff technique.
Yeah, Anand, you want to? Yeah.
Sir, most cases interlay, but as sir said, if the perforation size is subtotal or large, then 360 degree complete full cuff tympanoplasty.
Ravi, what is your?
I am trying to do by overlay technique nowadays. Overlay technique, sir. Overlay technique. Depending upon the situation, sometimes I can't elevate only epithelium. At that time, I am going to do by underlay technique, sir. And graft to be placed below the handle of malleus usually when doing underlay technique.
Okay. Then we come across this type of patient also. There is a middleization of the graft after tympanoplasty, and there is adhesion of graft to the promontory, to the ossicular chain, even in the anterior epitympanum there is adhesion. How to avoid the adhesion post-operatively, or what precautions, what care you can take while doing tympanoplasty? Because this adhesion all hampers your hearing outcome, and even sometimes there is a residual perforation. The main cause of that is residual perforation, is middleization of the graft and adhesion of the graft to the promontory or in ossicular chain. What you will advise to? It should not happen like this. Manish?
Sir, whenever there is a revision, basically we have to look for the midlayer mucosa, and we have to address the mastoid also. We have to open the mastoid, see if there is a any granulation or hypertrophied mucosa at the IS joint or blocking the adductus. We have to clear that. And then while doing revision, of course, 360-degree elevations of the annulus and full cuff. And then to prevent the adhesions, we have to take care of the midlayer mucosa. We should not injure the midlayer mucosa so that we can be avoid the adhesions post-operatively. Addressing the mastoid as well as the midlayer.
Each and every case, primary tympanoplasty also, we check patency of adductus to antrum patency. So each and every case we open mastoid antrum. Then meticulous handling of middle ear, and if perforation is subtotal or large, then I used to keep anteriorly sickle shape cartilage piece, so that eustachian tube pressure or air pressure should not affect the graft. That's only, sir.
So what I'd like to say two things. One is, of course, we are talking about adhesions, and we are talking about a failed tympanoplasty with a perforation. So one is, of course, if you have a tympanoplasty that is failed, firstly we need to, this is sequelae maybe of a remnant perforation, that's tympanic membrane that has gone on to the middle ear mucosa. So we have to keep in mind two things. One is, of course, there are different opinions about the adductus and the antrum and opening the, doing a cortical mastoid. There are different opinions on it. Like if Manoj was here, he would say absolutely no. I do it always, yes. But cause of failure has to be analyzed. Firstly, why did the tympanoplasty fail? Was it because of a eustachian tube dysfunction? Was it because something with the mastoid? Or was it because of a faulty technique or something wrong during the surgery? So divide it into three things. So if it's because of a discharge and the patient had a post-operative infection and then it just graft didn't take up after that, maybe you have to know, analyze how the eustachian tube is and what exactly is the ventilation of the middle ear. Now when we're talking about the tympanic membrane graft coming onto the middle ear, like what you have in the first picture there.
This one.
Yes, right. See, what has happened is that has occurred because there is some medialization of the graft that has taken place.
Yeah.
So that is either because of a negative middle ear pressure, because of a chronic period of time with an intact tympanic membrane, or these adhesions can also occur when there is a concurrent damage to the mucosa on the middle ear and the tympanic membrane, of course, so which is too close. So that causes the two things, because adhesions are nothing but a connection between two mucosal bands. So that's what we are looking at. So adhesions will form as a sequelae of a failed surgery for some reason. So a cuff technique, any technique you do, unless you are sure of the eustachian tube, you're sure of the middle ear, you're sure of the antrum, and to a certain extent, yes, the adductus patency, these kind of features would come into play.
What about the silastic sheeting sort of?
Silastic sheets were used by me. I used to put them into the middle ear, and maybe not used, and some of them have not been removed over a period of time. But then what I realized is that if we keep the middle ear mucosa intact to a large extent, we don't really need it. Because I'm a little worried about that foreign body inside the ear and causing some granulation, some amount of time, and you never know it can happen. So as a result, I used to do it. Dr. Anand Shah in Bombay Hospital still does it. and he has good results. But I feel that it's not really mandatory if you have a good, aeration, and the main aim is that the mucosa in the middle ear would also heal if you give it a good ventilation, and if you have a good amount of healthy mucosa around, it would heal. The most important point I look, like if you see in all these slides, you look at the middle ear mucosa with the vascularity.
Yeah, here.
So that's what I tell all my residents, you have a blood supply there. So if you have a vascularity there, so that means all the effectiveness of your antibiotics or steroids orally would be effective in healing that part of the mucosa. So if you strip the mucosa, then you have to put a silastic sheet, then there is no question. But as I said, divide it into and think of it more rationally rather than just approaching directly the retracted drum.
What about the gel foam in the middle ear? What is the fate of that? Some people used to.
I use it. Not in all patients, but I use one piece of gel foam to block the eustachian tube always. It's been done in the Western countries, and for those 2 or 3 weeks till the time the gel foam really settles down, the middle ear pressure is not really changed too much. So till the time the graft heals. Regarding gel foam in the middle ear, I put a very few pieces of gel foam in the middle ear. I do small pieces, but I have dipped them in Budocort respules. Budocort is so a little steroid inside the middle ear, because what I have realized that I have done 1 or 2 patients just for my own academic interest had a small perforation. So I put in an endoscope into the middle ear and through that perforation to check how it was. And in that process, what happened was I realized that about 15 days after the surgery, the middle ear mucosa was still quite inflamed and there was no discharge. So this was, I thought, post-surgical, handling inflammation. So the only way out for that is, of course, you have to give it time, but a local steroid was definitely useful. I use it sometimes, but not too much.
Well, this is about the cartilage tympanoplasty. Anybody of panelists, are you doing cartilage canaloplasty? Cartilage tympanoplasty?
Recently, sir, I shifted to cartilage tympanoplasty in almost of 95% of my cases.
Okay.
As I observed with my temporalis fascia graft take-up versus cartilage tympanoplasty graft take-up and results, they are much better with the cartilage tympanoplasty. That's why in my recent practice, since last 2 years, I have shifted almost all cases cartilage tympanoplasty. And I really found sutureless tragal cartilage harvesting, everything internally. No scars, no stitch.
Endoscopic?
No, microscopically.
Ravi, are you doing cartilage
No,
tympanoplasty?
sir, not doing.
Agarwalji?
I do in subtotal perforation only.
Nish, about you?
No cartilage. I will give you my honest opinion what I have done. In my early days of practice, I was worried about a residual perforation. Not too much patience, and we wanted success all the time. So I have used cartilage. It has worked. It has worked. Patients who have come to me with a second or third time surgery where there is no fascia available, temporalis fascia I thought might not work too well because there is total loss of vascularity around in that area, which each time you open the middle ear or the ear canal. So you do a revision tympanoplasty, well, we have to understand that the vascularity which you're seeing along the ear canal would reduce each time you do a ear surgery because of the healing. So the graft take-up rate is slower and slower in consecutive ear surgeries with the temporalis fascia. That's the only advantage where the cartilage basically has, where it can survive without vascularity for a very, very long time and take up, that's fine. But if you're talking about the hearing improvement of the patient after cartilage, there is definitely a big logical no for that, because it just, according to me, doesn't sound totally logical. Now, of course, as he said, if patient wants a scarless thing and you want to do it, and those are different things altogether, which we can't talk much. But I feel cartilage, unless it's really, it would be the last option.
Gajanan?
I am using temporalis fascia only, sir.
For type 1 tympanoplasty, temporalis fascia, when you go to type 2 and type 3, we use cartilage in between the incus and the stapes. Otherwise, for type 1...
That is for reconstructed tympanic.
No.
Sir, what is your experience with periosteal layer?
Periosteal layer?
Periosteal layer.
As a graft material? Yeah. I usually use temporalis fascia. Periosteal layer. Endoscopic tympanoplasty, Anand, you are doing routinely? No? Anybody from panel? From audience? Anybody? To Ritesh? He's not there.
I learnt it because of Ritesh. Because he usually takes endoscopes and puts anywhere. So he started doing endoscopic tympanoplasty around 4 to 5, I think Nashik conference ke pehle, 4-5 years approximately. So he was doing it regularly and the results are also good. You can say comparable with microscopic. So I used to, but I am very happy with elevating the TM flap, sir. TM flap elevation is quite comfortable and convincing. Though we do it very nice with microscope also. But even in just yesterday I wanted to discuss it. During stapedectomy, it's better to elevate the flap with endoscope. You can finish it early also sometimes. And the rest of the work you can finish up, middle ear work. Like that, it's a good tool. Those who are comfortable with endoscope can go with that. Of course, there are some limitations. You find something in the posterior superior area after elevating the flap, then you most of the times you need 2 hands. So those are limitations, but Ritesh can manage everything like this. I hand over to him.
So this is the next, already we have discussed this is tympanomastotomy, there is a mastoid opening. When there is edematous mucosa in the posterior superior region, or when there is a glue, or when there is a granulation tissue in the posterior superior region, is ideal to open the mastoid antrum, because many of the time we get the block in the adductus area. So it is better to open mastoid when you have doubt, it is a not clean, healthy middle ear mucosa. It is better to open the mastoid and see the adductus patency. This about the incus necrosis. There are various necrotic lesions. Here there is just slight necrosis of the tip of the lenticular process. Here there is a almost half of the incus body is incus long process is necrosed. Here the tip is disconnected with the handle. Here there is a just mucosal fibrous band around in between the incus and stapes head. How do you address this situation?
If there is a discontinuation in the IS joint, if the incus is mobile, I use cartilage as the interposing graft. If there is a the incus is not moving well, I take out the incus, refashion it, and keep it over the head of the stapes. Do the tympanoplasty.
In this minimal involvement of long process of incus.
If continuity is good, movement is good, I don't do anything. If I feel that stapes is not moving well, then I resect that and put a cartilage in between that.
If long process of incus necrosis process already started, then I prefer to
you will remove the incus and
disconnect the incus from stapes and prefer for Mahadevya's cap. Mahadevya's cap. That means Vijendra sir's technique, cartilage cap.
Finish? Is it some glue or like?
Yeah, there are many things you can do. It all depends on, one is what is the disease the patient has. Like if the patient has this disease without any active cholestatoma.
Yeah, it is a retraction pocket.
Retraction pocket. So then there are many things you can do. Now, like for example, in the first one and the one below that, there is just like a little band or a necrose thing. What I have a lot of videos, but now it's too late. But what I have done off late is we have to first denude the mucosa. So this band has virtually no value when it comes to sound conduction. Even though it might move, but it has no value. We are presuming that the incutomalleolar joint is okay. We are presuming that the stapes movement is fine. So it's just the incutostapedial joint that's the problem. What I would do is, we have a lot of options. One of the common option, of course, is you can remove the incus, have a good patency also, and make a cap, and like maybe we did saw is to put it under the malleus and try to refashion the assembly. But you do that, it will still give you a 30 to 40 decibel airborne cap. So that is important. So age of the patient, 30 decibel, he will not have normal hearing or close to normal hearing, very unlikely. The reason behind that is that the angulation of the incus or the incutomalleolar angle is very important for the linear conduction of sound onto the stapes head. So just connecting one ossicle on top of the other is not going to give us the perfect sound results.
Like this, na? In this patient, there is a space in between.
Yes.
Incus
Now these are the cases. These are the cases.
Here, if you see, the lie of incus is different. There is no space in between.
Correct.
These are two different cases.
Correct. Now these are the cases. For example, one is of course you can refashion the incus. Second, you have a prosthesis which you can do, which we have the titanium prosthesis from Kurs, which Vincent also uses, in which we have what we call as a silastic banding. So there is a silastic band which is put on the stapes, and then it goes up, and then you pull the malleus and it sits on the malleus. So it's like assembly from the malleus on directly onto the stapes and the foot plate. That is one, but that's expensive. It's not possible for everyone. One of the more common things which I have done very effectively is glass inoma.
Yeah, yesterday talk about.
Yes, now in that, like even in the first one, even if there is a gap, for example, we take the incus, we gently, very gently, there is the facial down also, we gently, very gently, we move the incus and mobilize it a little bit towards the stapes head. By a few the gap would definitely reduce. You make the incus head bare, the stapes head bare, and there is a glass ionomer which can be easily put there over the two, forming a sort of a channel, and that gives the same linear action and excellent stability.
But here in this case?
In this case also we can use it, but in this case the problem here is the bone of the incus doesn't look too healthy. The bone looks a little more diseased. So I don't think for that, in this case, maybe removing the incus would be a better idea, and then either putting a prosthesis would be a better idea. But if the incus is somewhat healthy, like in that case, we can also cut that small tip and put in a glass ionoma.
Anand?
The same as sir said, the removal of the incus in this case and reshaping it and keeping it with the stapes. And I use cartilage. I don't have experience with the TORP or PORP prosthesis, which I don't prefer.
Okay. This is reshaping of the incus and keeping in between the malleus and the stapes head. Okay.
So Minesh, when we put a glass isomer there, you also make a continuity, but what about the IS joint? It will be a fixed joint then.
Yes.
Does it make some sense or difference?
Normally if you see the IS joint which is there after putting the glass ionoma, even in a normal person, the IS joint doesn't have too much of mobility. The vibrations go from the incus onto the stapes pushing it. So the IS joint is not like the foot plate. It is always a more or less fixed joint. So whenever you have a fixed IS joint, it is when we are doing a stapes surgery and we are talking about the IS joint, the joint is never fixed. It is the foot plate that is the problem there.
So we can convert in the AB gap what we get after.
We get AB gap because the basic logic now all over the world, if you go, try to preserve whatever is there in the normal anatomical position as an option, as a first option. I mean, God has given us 3 ossicles in certain linear angles with some reasoning. So try to preserve it if it's possible. Well, if it's not possible, of course you can't risk a disease incus remnant there with a glass ionomer and just trying to give a patient a hearing. Yes, but try to preserve as much as possible.
And do you have to scale up the mucosa from the bones while
Most
putting
of
glass isomer or?
All the bone has to be bare. The bone all has to be bare, and the simple way to scale it is use a gel foam and gently scrape it because the mucosa is very, 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 very delicate. So simple piece of gel foam can do it. Of course, you have to be careful when you're doing it over the stapes head also. Otherwise, you might actually do the wrong thing there. So you have to be careful, but gel foam helps, and it's not very difficult at all.
Other thing, malleus head can be amputated, and that can make like a cap like this, and you can do the sound transmission. Here I have used the cartilage. Can this be done? If we are, this is the cartilage and there is a reconstruction of the posterior superior canal. These are the different things we can think about the reconstruction of the tympanic membrane. What about the surgery of the tympanoclerosis? When you will go for a plain grafting of the tympanic membrane, and when you think of opening of the mastoid and see for the ossicular fixation, will you stage the, at what time you think you will stage the procedure?
So, if you have a case of tympanoclerosis, send it to your friend. I will say.
Predictable results.
And tell him I give you all the surgical charges as well. Now, jokes apart, I would say that if you have something like this, like in the first picture, and ossicular chain is okay. It's a simple myringosclerosis. Okay, it's not a bad idea to close it, but you have to remove all the sclerotic patch and maybe graft more or less the full eardrum. I have done tympanous sclerosis in IS joint, taking inspiration from Dr. Vijayendra, and wasted 6 hours over it, and coming back like a he-man. Patient had good hearing for 3 months. After 3 months, he again came back to me the same hearing loss. So I think if it is to do with the ossicular chain, with you gauge the amount of hearing loss. If it's only a 20-25 decibel hearing loss, it's very likely that ossicular chain is not affected.
Yeah.
You can go ahead and close the perforation. But it's a larger hearing loss, you have to give a patient a guarded opinion of what you can do regarding the hearing part of it.
The staging part?
I would preferably, if you have something like in the third picture with a perforation and a stage and a sclerotic part near, I think that's the round window, I don't know, in that part all over that area,
Yeah.
I would basically put a graft, try to remove how much over is possible, but give the patient an idea that if it recurs again, you have to go for a hearing aid. The sound conduction, I mean.
Okay. We can see the extent of the tympanostosis in this patient. This extensive tympanostosis, particularly in the anterior part of mesotympanum. And in this case, I have opened the mastoid antrum, clear all the tympanostosis around the incus. This is an endoscopic view from mastoid, and ossicular chain is new. Now that all ossicles, they are mobile, and I have kept the. If there is extensive tympanostosis, you can even go ahead and opening the mastoid and remove all the tympanostosis around the ossicular chain, see the patency of the adductus, and you can put the graft. But what about the tympanostosis, staphylotomy in a tympanostosis? Finish.
You see, if it's the tympanosclerosis of the round window, or maybe ossification of the round window, like how we discussed yesterday, it's okay. I mean, that can be managed. Now, if you are talking about, like in the first picture, I don't understand if that is the tympanosclerosis, is the white one there,
This is the
So anyway, I would say that has to go. Anyway, we are removing the suprastructure, that has to go. So that doesn't matter. The problem arises, according to me, I have seen it, is when the tympanosclerotic plaque, it travels from the stapedial crura onto the oval window, around in that area. So we have to basically remove the tympanosclerotic plaque, then remove the suprastructure, and then put in a piston. That we can do if you're going for a stapes surgery. But the chances of recurrence is always high. You might have this patient coming back to you again with a tympanosclerotic plaque and causing you a conductive hearing loss again, in spite of you putting a good piston. So with tympanosclerosis, it's a very unpredictable thing according to me, even in the best of
the
ways.
experience of staphylotomy in the patient of tympanostosis?
I have done about 5 of them, to be honest, and 3 did well. In 2, there was not good closure of the airborne gap. To be honest, it wasn't a good closure. It did help, but it wasn't really a great closure. Now, that's a different thing that the patients are happy about it and they are not really complaining. But if you see personally, in spite of doing a good stapes surgery, sometimes you might not get a good result in tympanosclerosis up to the whole window.
This is a situation when there is a absent of suprastructure stapes. Then how to manage this patient? The case of cholestoma, intact canal wall technique, and absent of suprastructure stapes. Stapes footplate is mobile. Rajiv?
Two things it can be done. One is you can use the tragal cartilage, make it a L shape, strut, and as well as and then put a graft over it, or go for a prosthesis. Generally, I try to avoid. I use cartilage refashioned in a particular way.
Gajanan, do you use ossicle?
Boomerang cartilage graft,
Boomerang
and also support boomerang cartilage from upper side also, so that give good tension from above also. In general, boomerang cartilage from whole window to hypotympanum, and we break the elasticity by taking incision. And I many times I support so from superiorly also with cartilage piece.
boomerang cartilage with another cartilage over that, and above that there is a neo-temporal. Finish.
Well, here though, if it is affording and if it is a good patient, a good titanium prosthesis would help, because you have to keep something over the whole window and keep a prosthesis from there which touches the malleus and it will help. If you don't have a prosthesis, then of course you have to use a cartilage like they do, but the tragal cartilage according to me is very soft for this. I have to use septal cartilage. Septal cartilage, because tragal cartilage is just too soft. It's not going to withstand the heaviness of the tympanic membrane or maybe the malleus weight over it over a period of time. It's according to me too soft unless it's a very good hefty male and having a good tragus, because tragus cartilage is usually according to me not that strong. So I use a septal strut in many of the videos which I've seen, so in which I take a small septal piece from the septum, harvest it at the same time and use it, and it works. But of course the airborne gap with the septal tragal or whatever you do would not be, it will still be there around 35 to 40 decibels. So if you give him that also, still you're a great surgeon.
I use conchal cartilage because anyway in mastectomy we have to do the conchomeatoplasty. So at the same time, whatever conchal cartilage I harvest, I make a L-shaped cartilage and put over the footplate of the stapes.
Anand, Raju, Ravi.
I started to use septal cartilage homografts nowadays, preserved in 70% alcohol. It works very well, sir.
The tragal cartilage in a boomerang fashion.
Okay, this is the how we can even try it. Raju had said this is a cartilage one, yeah?
In 6 picture, here is this just L strut.
Yeah.
I support from superiorly also.
Here also, from here?
Piece.
When we take the septal cartilage piece, we put in a small fascia over the whole window. The cartilage is like this V strut which people use, but the upper end has to be a little U shape which goes under the neck of the malleus. So, the malleus. So you have no ossicle there like in the first picture. So that's what the case there. So we have to have
a remnant of incus is there, no?
Incus is here.
Incus is here, but that's virtually of no use at all. Okay, incus is no use at all. So either you can remove it or you can refashion or you can keep it as it is. It doesn't matter. But now we need to do something about the hearing part of it. So for the hearing assembly, you have to have some assembly going from the whole window up to the malleus. So either you have a prosthesis, or if you're having a cartilage, you have a cartilage directly from there going to the malleus. It has to have quite a sturdy assembly, because I mean the boomerang is something which I've tried, but we look at the results in 10 years. The assembly according to me can be quite unpredictable over a long period of time. Maybe others have better results, I don't know.
This is a situation where there is a canal wall down procedure, the footplate of stapes mobile, is a facial nerve. Here there is a dehiscence facial nerve, and here is a prolapse facial nerve over the stapes footplate. How to do the assembly in this patient?
Cartilage pressure don't do any facial paresis.
Can you think of putting a Teflon piston, titanium piston like that? When
In stapes surgery also.
When there is a dehiscence facial nerve?
In stapes surgery, na?
No, in this case.
In this case, no. L strut, cartilage.
I try to avoid any pistons over there. Cartilage is the better.
Finish?
Even it touches the facial nerve, nothing will happen.
Yes, of course, cartilage is one option, but then again, as I said, if you have this MVP prosthesis, which go from the vestibule up to the malleus or also to the tympanic membrane, there is space there. Sometimes the prostheses are very, very fine. The last picture only, I'm not so sure. So there is space there where it can go. But for the juniors, I can also tell them, in case you're not sure of what to do, close it, give the patient a hearing aid. You don't experiment something at the risk of the facial nerve. If you're not sure, close it, that's fine. But I think cartilage or maybe a titanium prosthesis which is very fine will help.
I use some titanium prosthesis in this type of patient. They are very well follow-up patient, they are good, this hearing is better. Put a cartilage, small piece of cartilage over the titanium prosthesis and put a graft over that. This worked very well. But nowadays I am routinely using cartilage. This is the last case. This is a patient with extensive cholestoma having lateral semicircular canal fistula, and here there is a lateral semicircular fistula, exposed dehiscence facial nerve, and suprastructure stapes. How to reconstruct these two cases? The hearing reconstruction.
Is that the pick under the facial nerve?
Yeah, it is 360 degree. It's dehiscence. Total facial nerve is dehiscence. There is a micro respirated below the facial.
But why was the pick put this way?
No, just to say that.
Oh, to show us.
Demonstration. That's all. Just 360 degree.
Sorry. I thought, I don't know, it's a magical
No,
pick.
no. It is for
Because I wouldn't do that. I would get very scared to do such an adventurous thing. But yes, okay. So, I think, the most important thing is clearance of the disease.
Yeah.
Because these are some really bad conditions, most important clearance of the disease. Well, regarding the fistula, depending if you have a bony fistula, a membranous fistula, you have to close it. But in these cases, we have such severe cholesteatoma, avoid any titanium or any prosthesis, because those microscopic infection which can take go on the titanium as a nidus for infection can be troublesome. So if you have to reconstruct, use cartilage or use any normal material. And but the main aim is remove the disease. Also think about staging the disease if you're not so sure. So if you don't want to really think about an ossicular reconstruction, remove the disease, preserve the facial, wait for 3 to 6 months. After 6 months, go ahead and then you can simply do something for the ossicular chain if the patient wants. Or you can also advise him a hearing aid after that time.
Okay. Anand?
Same, sir. I would like to stage if the patient is really concerned about hearing. My first aim is to give him safe and dry ear.
So this is a post-operative thing you can expect from our surgical all skills. Here you can see that is a neotympanum. Here is a cartilage over the stapes head. This is an open cavity, and this is also cavity. This is an intact canal wall tympanомastectomy with a cartilage in place. This is how we can expect the post-operative dry ear and good hearing. Thank you all the panelists for their expert opinion. It's valuable for the juniors and old.
So thank you very much, sir, for the wonderful panel. I would like Dr. Maruti Kalyankar, sir, to felicitate all the panelists. First, Dr. Minesh Juvekar, sir. Dr. Rajiv Pastapur. Dr. Sandeep Agrawal, sir. Excuse me. Dr. Ravindra Ghumre, sir. Dr. Gajanand Kashit and Dr. Anand Gore, sir. I would like to call upon stage after our AOI secretary, sir, Dr. Ritesh Bhagyavan, to fill AOI president, sir. Maruti Kalyankar, sir. Kalyankar, sir.
Oh, sir.
I would like Dr. Shrikant Savji sir to felicitate our chairpersons, Dr. Shaligram Tonde sir, Dr. Priya Shende ma'am, and Dr. Rameshwar Pawar sir. Now I hand over all the proceedings to Dr. Jitendra. Yes.
Now we come up to our last part of the conference, the prizes. So we had 3 categories for handover केला नाही. So we had 3 categories. AO Aurangabad Consultant Award paper. Then for the first time we started Dr. Ashok Rege PG Award paper, and for poster presentation. So for each category we are giving first and second prizes, but for the Dr. Ashok Rege PG paper award paper we have decided to give 3 prizes instead of first and second. We are giving first, second and third, as we are repeatedly telling this is PG centric conference, this is meant for PG. So we want to encourage our PGs, so they should come up with in more number. In next conference they should come up with presentations, paper presentation, poster, and they can have their own panel discussion also next conference. So first category is AO Aurangabad Consultant Award paper, and second prize goes to Dr. Shailesh Agrawal. I request Dr. Sunil Deshmukh sir, Scientific Committee Chairman, to felicitate Dr. Shailesh Agrawal. Sir, तुम्हीच देता का क्या? Sir, Sunil Deshmukh sir, please. आगे. First award goes to Dr. Maruti Kalyankar sir for AO Aurangabad Consultant Award, and Dr. Sunil Deshmukh sir will felicitate Kalyankar sir. Category is Dr. Ashok Rege PG Award paper. Third prize goes to Dr. Saloni Chaudhary. I will request Dr. Sunil Deshmukh sir to felicitate Saloni Chaudhary. On her behalf, Namrata will accept the prize. You don't need to go. Second prize is to Dr. Namrata Dobre. Third category in the awards, the poster presentation. Second prize goes to Dr. Kiran Sharma. First prize goes to Dr. Ajinkya Raval. I would request Sunil Deshmukh sir for one announcement to be made by him. Mike.
So we have enjoyed very rich academic surgical feast along with orations, guest lectures. This is a concluding event of this MORCON 2022. So on this dais, I appeal MORCON 2024, whosoever branch is willing to take, they can inform our AY Aurangabad, who is the next host in 2024. So that is the most important announcement which I want to make, which we are going to conduct. Okay. So if the branches like other Nanded or Latur or Parbhani, they are willing, they can tell us. Otherwise, if nobody is taking, 2024 will be hosted at our Government Medical College, Aurangabad. Thank you very much. Over to Jitu. Okay, Sachin, Dr. Sachin, Professor, Nanded.
Thank you, sir. Good afternoon to all seniors, respected delegates. Nanded ENT Association is eager to hold and organize fourth MORCON to be held in 2024 under the eminent guidance and leadership of Dr. Maruti Kalyankar sir, Dr. Sanjay Patange sir, and Dr. Kumar sir. We hope.
Please go.
We hope.
शब्द देव ऑन रेकॉर्ड्स घेतात.
We hope same affection, same love, and more than this, so that we can deliver more than this to you also. Thanks.
President, congratulations to both of you and Evan. Yes. Thank you. Thank you so much.
So thank you very much, everybody. Now we come to last part of the ceremony, last part of the conference, the vote of thanks. So I would like to thank all the delegates, first of all, for making this event successful. All the delegates from Marathwada, Vidarbha, rest of Maharashtra, out of Maharashtra. We have delegates from Karnataka also. So
vote of thanks करायचे trade वाले येत आहेत.
yes. So I would like to thank delegate first, then comes the later part. First of all, I would like to thank the scientific committee chairman who has taken very much efforts to host this conference. He was through all the process of the conference, so I would like to thank him from bottom of my heart. On the behalf of association, I would like to thank him. Thank you very much, sir. Then I would like to thank the co-host of our conference, that is MGM Medical College, management of MGM Medical College, who is always supportive. So our Dean sir being part of our association, it is always easy for us. So I would like to thank MGM Management, Department of ENT, HOD ma'am, Reena Vare ma'am for support from the ENT department, and not to forget our residents. Like I said in the panel, they were backbone of our conference, which whatever part was done in MGM. Then comes the major role of association, AO Aurangabad, President, Secretary, Treasurer and office bearers, who has worked tirelessly for last few months, not only to get registrations, organize funds, but to make this event successful. So I would thank all office bearers for making this event successful, and the most important, as mentioned by Treasurer, he always interested in trades and money. So we would like to thank our supporters, sponsors, pharma people, and whoever has supported us to make this event successful. Thank you very much.